रूपमा कार्यरत हुनुहुन्छ। उहाँबाट MBBS गर्नुभएको छ भने कम्युनिटी मेडिसिनमा MD गर्नुभएको छ काठमाडौँ मेडिकल कलेज टिचिङ हस्पिटल काठमाडौँ युनिभर्सिटीबाट। निर्मला श्रेष्ठज्यू आफ्नो प्रेजेन्टेसन।
सर के अरे शेयर भइरहेछ कि भइरहेछ छैन मेरो प्रेजेन्टेसन?
भइरहेको छ।
Good evening, namaste. Today I'd like to present our research work titled Fear of COVID-19, Perceived Risks and Psychological Distress Among Health Workers During COVID-19 Pandemic in Nepal. As we all know that we are in the midst of pandemic. COVID-19 began from China and was declared as a pandemic on 11th March 2020. The emergence of this disease, COVID-19, and its consequences of this disease, of this pandemic, has led to the fear, worry, psychological distress among the people worldwide, and the healthcare workers are not an exception. And during the time we started this study, there was no any research regarding the impact of COVID-19 pandemic on mental health status of the healthcare workers in Nepal. So this was our simple attempt to assess the perceived fear of COVID-19 and psychological distress and associated factors among healthcare workers in Nepal during COVID-19 pandemic. A cross-sector web-based survey was conducted among 427 healthcare workers who were working in different organizations of Nepal. The information was collected from April to June 2020 through a structured questionnaire prepared in a Google form and sent to the respondents through emails and social media. The confidence sampling method was used to collect the data. A standard scale was used to measure 3 dependent variables of our study. Perceived risk was measured using a 10-item scale. Fear was measured using 7-item fear scale. And psychological distress was measured using Kessler 10 distress scale. And descriptive statistics.
Sorry, तपाईको आवाजमा डिस्टर्बेन्स आइरहेको छ, सायद त्यो राम्ररी लागेको छैन जस्तो छ। Sorry. Go ahead, please.
Descriptive statistics and bivariate and multivariate analysis was performed at 5% level of significance. So all clear idea, sir?
China Tara, go ahead, please.
Okay. Ethical approval was taken from Ethical Review Board of Nepal Health Research Council. Result, out of total 427 respondents, nearly 60% of the respondents were of age group 19 to 29 years. And half of the respondents were males and half were females. And 48%, nearly 50% of the respondents were doctors and followed by nurse. And 38.4% were government employees. This table shows the socio-demographic characteristics of study population. Regarding the preventive measures adopted by the healthcare workers, our research showed that more than 90% of them, healthcare workers of Nepal, adopted different preventive measures, like covering the mouth when coughing and sneezing and immediately washing hands after it, wearing masks regardless of presence of symptoms, and washing hands before examining or touching the patient, and washing hands after touching contaminated objects. Regarding access to enabling environment to healthcare workers, 71.2% of the healthcare workers reported that they never had access to soap and water when they needed them. 54.6% of the participants reported that they never had access to sanitizers when they needed them. and 44% of the participants reported that they never had access to face masks. Only 27% of the healthcare workers got emotional support, sometimes from their organization, to work against COVID-19. This table shows the enabling environment reported by the healthcare workers during COVID-19 pandemic. Now the status of perceived fear and psychological distress. Mean perceived risks of COVID-19 was 31.9 out of 50, maximum as measured by 10-item scale, and 53.2% of the healthcare workers reported to have mild to severe fear of COVID-19, and 1/4 of the respondents were found to have symptoms of mild to severe psychological distress. This table shows the status of perceived risks, fear, and psychological distress among healthcare workers during COVID-19 pandemic. In bivariate analysis, it was found that there was a significant association between perceived risks and gender, and perceived risks of COVID-19 was significantly higher among those who had handled fever cases and were in contact with an individual with suspected COVID-19 or infected materials in last 14 days. Wearing masks regardless of presence or absence of symptoms, washing hands before examining the patient, and washing hands after touching contaminated objects were also associated with perceived risks. In multivariate analysis, gender, types of family, and job category, handling the fever cases in last 14 days, using of masks and perceived risks were significantly associated with fear of COVID-19. And the odds of psychological distress was found to be 1.7 times higher among female healthcare workers when compared to the male, and the relationship or association between the gender and psychological distress was statistically significant. This table shows the multivariate analysis of fear of COVID-19 with explanatory variables, and this table shows the multivariate analysis of psychological distress with explanatory variables. We acknowledge some limitation in our study. First, our sample was non-random sampling from the population, so this sampling method could introduce the selection bias. And the study was conducted in the initial period of the pandemic when the COVID cases were 49 on the day we started the data collection, and around 4,100 on the last day of data collection. Thus, the outcome may change along with the time. The outcome may change along with the increasing number of the cases, among the healthcare workers, and the phases of the pandemic in Nepal, and the experience of healthcare workers in the management of COVID-19. And conclusion, although the access to enabling environment was found to be poor, the personal preventive measures adopted by the healthcare workers of Nepal was satisfactory. As I have already mentioned that the study was done in the initial period of the pandemic, and the Nepal was on the second stage of pandemic at the time, and the government had already endorsed the lockdown and was in the preparatory phase. So the people were afraid of being infected with the COVID-19, so they were hurried to buy many masks and the gloves and the sanitizers, and this medical halls and the supermarket was out of stock of this material. So this could be the reason that most of the hospital at the times where they faced the shortage of this material. And high level of the perceived risk and fear of COVID-19 was observed among the healthcare workers. Similarly, 1/4 of the healthcare workers had mild to severe symptoms of the psychological distress. From this result, It doesn't mean that we cannot say that the healthcare workers who had the symptoms or who showed the symptoms of psychological distress and the fear, symptoms of the fear, should be regarded as a pathological, and they should be they need a clinical management. But if these symptoms of psychological distress or symptoms of fear or this risk perception, it persists for a long period of time, even after the pandemic is resolved, then at that time, the health workers, they need clinical management. A general gender, family type, job category, handling the fever cases, using of masks and the perceived risks were significantly associated with fear of COVID-19. And gender was significantly associated with perceived risks and psychological distress. Recommendation. Adequate attention should be given to the mental health and psychological aspect of the healthcare workers, and it's very important to ensure the accessibility of enabling environment and including the emotional support for the workers at the healthcare setting. Uh, the healthcare workers, whether they work in the hospital or in the communities, are very crucial to the healthcare system. With the ongoing community transmission of the COVID-19, the disease burden in Nepal are increasing and rising and expected to rise further in the future. More cases in the community means more cases in the hospital. And this situation will definitely put the healthcare workers at high risk of getting infected with the SARS-CoV-2. Therefore, to ensure the physical well-being of the healthcare worker, to ensure the psychological well-being of the healthcare worker, as now the government of Nepal strategies should focus more on controlling the community transmission. And the government can do it by intensifying this awareness program in the community among community people and motivate them to follow the preventive measures that are recommended by WHO, like physical distancing. Where the physical distancing is not possible, wear masks, and frequent hand washing technique is very important. And if this preventive measures recommended by WHO, if we applied this, adopted this measure by whole people, whole community, then definitely this will slow down the transmission of the virus. But it seems that people are not have belief on this preventive measures. So that's why the intensification of this awareness program is needed. And number two, the government can mobilize more public health professionals at local level to work with the local government, because the public health personnel are the key persons who have competence to change the behavior of the community people, and they have knowledge on this risk assessment, they have knowledge on this risk communication, they have knowledge on contact tracing, they have knowledge on resource management, and they know the importance of community participation. Community participation, the community involvement, this community engagement are very important to stop this community transmission. And another thing, other strategies that our government can adopt to improve the well-being of the healthcare workers by strengthening the qualitative and the quantitative research to understand the true picture of mental health status of the healthcare workers at each phase of the pandemic. And another thing is our study and several other studies have shown that हजुर सर के भन्नुभयो
टाइम सिद्धियो चाँडै ऱ्याप अप गर्नु होला
shown that the female healthcare workers are more likely to have the symptoms of psychological distress as compared to the male. So it's obvious because the female healthcare workers have dual responsibilities like taking care of the family, taking care of their children and their job at the same time simultaneously. To address these issues, the government should do the gender analysis. Gender analysis is the key because it examines the particular need of the female healthcare workers, including the physical well-being, physical health, psychosocial health, and the working environment. At last, what I want to say is that time to time and emotional support is needed from the health administration to the healthcare workers, and so that they get encouraged to work in this dire situation. And another thing is the hospital administration can do to improve the psychological well-being of the female health workers. They can deploy minimum number of the female healthcare workers for the duty, and this may be beneficial for the physical well-being and the psychological well-being of the female healthcare workers. Thank you.
धन्यवाद डाक्टर निर्मला श्रेष्ठज्यू राम्रो प्रेजेन्टेसनको लागि। यसपछिको प्रेजेन्टेसन डाक्टर मनिषा सिगदेल को रहेको छ। उहाँ ओबिगाइनी युनिभर्सिटी हस्पिटल न्यू ब्रन्सविक न्यू जर्सी, उहाँले जर्ज टाउन युनिभर्सिटी स्कुल अफ मेडिसिनबाट ग्रेजुएट हुनुभएको छ। एन्ड सी इज भेरी प्यासनेट अबाउट वुमेन्स हेल्थ and its impact in current global crisis on mental health. Dr. Manisha Sigdel.
Hi, I just wanted to say thank you so much for this opportunity to speak about maternal and mortality and morbidity, especially during this time. So thank you very much for having me here. So today, everybody can hear me clearly? Yes, okay. So COVID-19 pandemic and its effect on maternal mortality and morbidity in the United States. So most of the data that I'm going to be speaking about today is mostly in the US, but it can also give kind of a frame of what's going on in maternal mortality and morbidity here. And this information can be used back home as well in Nepal. So pregnancy and childbirth can be a time of very much of joy and excitement. However, it's very imperative to understand that perinatal and postpartum periods are a time of risk for women, especially during COVID-19 pandemic. Currently, the understanding is that more people that you interact with, the closely that you interact with them, and the longer the interaction, the higher risk that you have to getting and spreading COVID-19. We don't have complete information about long-term adverse effects as it's continuing to develop of COVID-19 on the fetus, but we do know that there is a high mortality and morbidity of pregnant women compared to that of non-pregnant women. It also affects women
Dr.
in.
Monica, do you want to share
yes.
your presentation slide?
Yes, hold on a second. Let me see if I'm able to share it. Okay. Let's see. Okay, perfect. So we know that this the number of women that it affects not only affects there's a high risk of mortality and morbidity in pregnant women, but it also affects women in minority communities. So it's really important to know how that can impact the Nepalese community as well in the United States. Additionally, there are considerable racial and ethnic disparities in pregnancy-related mortality and morbidity that is further exacerbated by COVID-19 pandemic. So maternal data. So current maternal data, it is gathered by CDC, or Centers of Disease Control and Prevention, and the Division of Reproductive Health that collects the data and analyzes the issue related to maternal health in the United States. And they've been at the forefront of collecting data for COVID-19 related pandemic as well, the information. CDC has turned its focus on gathering data to better understand COVID-19 on maternal and neonatal mortality and morbidity. The CDC data is collected based on copies of death certificates for women who died during pregnancy or within 1 year of pregnancy. And there is a little bit of caution to this as well when we're looking at this data, because if there are women who've already had respiratory type of illness in the past, and they are further impacted by COVID-19 related issues. It might not be written down, or in their death certificate, it might not say that it is specifically due to COVID-19 related issues, and more because of their comorbidities that they already had in the past. So this data can highly underrepresent the amount of mortality and morbidity that we see and relating to COVID-19. So pre-COVID-19 related data, in order to analyze, how COVID-19 has affected mortality and morbidity in maternal health, we have to also be able to assess what was happening before. So prior to COVID-19 pandemic, reported pregnancy-related deaths in the United States steadily was increasing from 7.2 per 100,000 live births in 1987 to 16.9 deaths in 100,000 live births in 2016. So it had been going up. During 2011 and 2016, the pregnancy-related mortality ratios were 42.4 deaths amongst 100,000 live births for Black women versus 13 amongst white non-Hispanic women. So as stated before, there is a high number of ethnic and racial disparities even within this mortality that was pre-COVID. Studies show that increasing number of pregnant women in the United States that have a chronic health conditions such as hypertension, diabetes, and chronic heart disease have placed these women at a higher risk of pregnancy complications with COVID-19. And it just so happens that a lot of the women who are in the ethnic minorities are the same women who have these comorbidities in the first place. So they're highly more likely to be impacted by the COVID-19 related comorbidities. COVID-19 related maternal data by CDC. So current CDC states that there are about 6 million total cases of COVID-19 with about 180,000 COVID-related deaths. And in a Mortality and Morbidity Weekly Report, a study by CDC suggests that pregnant women with COVID-19 are more likely to be hospitalized and also are at increased risk for intensive ICU admission and the receipt of mechanical ventilation than non-pregnant women. Currently, there have been about 20,000 pregnant women who have been affected by COVID-19 with about 44 deaths. And these among these women who have been hospitalized, the age frame is between 25 to 29 with the highest rate of COVID infection. And there are a lot of women who are first-time mothers or first or second-time mothers within that 25 to 29 age gap. Usually these women are they don't have a lot of health-related issues. This is the first time they've ever been hospitalized for anything. And so to see a very high rate, even within that time frame, is pretty significant. Currently the majority of the women, again, are of ethnic minorities. And in addition to health-related condition, many hospitals, what was happening was that, going back to the note that was made in the earlier presentation, that many hospitals diverted and lessened the services that were provided to pregnant women. So a lot of women were coming in, delivering on their own. They had no support person, especially in the New York, New Jersey area, just because the hospitals wanted to limit the number of people that were with these pregnant women. And it was difficult for them to just access these services and come to the hospital in the first place. And when they were here, it was hard for them they were delivering on their own. So they didn't really have social support, which increases their morbidity in terms of postpartum depression and just postpartum related illnesses in general. According to latest data that was updated on September 10th, pregnant women right now that are affected with COVID-19 in the US are about 20,000 with total deaths of 44 and hospitalized cases of about 4,800. And the ones who have been admitted to the ICU has been about 200, and people who have been admitted to the ICU that have required ventilation is about 77. And this data is based on Centers of Disease Control and Prevention. So how has OBGYN responded to COVID-19 pandemic? So American College of Obstetrics and Gynecology and also Maternal Fetal Medicine, they have come up with a guideline or a protocol in terms of how to assess women who are coming in and how to triage them when they are in the hospital. So basically what we do once a woman comes in is we ask for symptoms. So do they have any fevers or coughs? the most common symptoms that we find in pregnant women when they come in is no symptoms at all. So they have no symptoms, don't remember being around anybody who has had COVID or has been sick recently, and so they are completely asymptomatic. And right now, any woman who comes in and who is admitted for delivery have to have COVID-19 testing done. And so we have found that most of the, especially at our hospital, most of the women who are coming in have no symptoms. But some of the other symptoms that we do check for are fevers and cough, which have been the second most symptoms that I've seen. Shortness of breath, chills, repeated headache, sore throat. And if there's any type of symptom that is suspicious, then we will do COVID-19 testing on them. And if they continue to have repetitive symptoms, then we have a rapid COVID-19 testing, which are the accuracy is not it's not certain. So we also do PCR testing, which takes a little bit more time, about like 6 hours or so, whereas rapid testing is about 1 hour. So we will test them repeatedly, just because we know that there is a high false negative rate, even with the testing that we do have. So once we kind of gauge patients and see what risks they fall into. So if they are elevated risk, then we separate them from other women who are admitted as well, and we will do the PCR. That takes a longer amount of time, which is a little bit more accurate than the rapid test. Then once they are cleared with that, then we will have them in the regular floor. And if they have a really elevated risk, we use anticoagulants as well. There have been some studies that people who have been affected with COVID-19 have higher coagulopathy, and so for that reason we assess their risk to see, and being pregnant in general, you have more higher risk of having clots. So we will put them on, depending on the risk, we may or may not put them on anticoagulation prophylaxis as well. And then we'll assess clinical and social risks, and then we'll do the treatment according to what risk level they fall into. So precaution prevention is key. So limit close contact with interactions with people as much as possible when going out with others outside of your immediate household. Make sure that you're wearing a mask, and note that wearing a mask is not a substitute for everyday prevention, just like washing your hands frequently or avoiding close contact with other people. Caring for newborns when mother has COVID-19. So this is kind of like a ongoing protocol here as well. In the beginning, when we had absolutely no data on COVID-19 and when it was just starting
Dr.
to come
Nishita, you have one. Dr. Monisha, you have 1 more minute.
Sure, thank you so much. We were separating mothers and children, and again, this in turn increases the amount of social constrictions that mothers were having. First of all, they weren't having any support, and then on top of that, we were separating the mothers and their newborns. But now we have seen that some newborns have been tested positive. However, these newborns, we don't know when these newborns have gotten the virus, before, during, or after the birth. And also many newborns that have been positive for the virus have had mild or no symptoms. So now we are keeping the mothers and the newborns together, just because it increases their psychological well-being. So that has been our protocol from now. So where do we go from here? So long-term effects of COVID-19 pandemic has not yet become clear, and this is a continually developing issue. And these effects are imperative for women and families to understand if they're undergoing preconception counseling, currently pregnant, or are going to be delivering soon. So some of the takeaway from this, from my lecture, is that pregnant women indeed do have higher risks of mortality and morbidity, especially if they already have an underlying disease in the first place when they're affected with COVID-19. Much is still not known about COVID-19 and how it affects long-term in the newborns. However, right now, newborns have had mild or no symptoms, even if they are positive. And especially the main thing is take precautions if you are pregnant, have a newborn, or in the phase of preconception counseling. Thank you so much.
Thank you. Thank you, Dr. Monisha. for nice presentation. यसपछि Dr. Matiram Poon को presentation छ. उहाँ अहिले University of Calgary मा PhD गर्दै हुनुहुन्छ. उहाँको research interest hypoxia, sleep disorder, breathing, high altitude hypoxia, ventilator control र neurocognitive function रहेको छ. Dr. Matiram. Question answer session यसपछि सबैको presentation सिद्धिसकेपछि गर्छौं र यसपछिको moderation Dr. कुश श्रेष्ठले गर्नुहुन्छ.
All right, thank you. Yes, so I guess we can hear, right? Can you hear me, Satyaji? Yeah.
Hazur.
All right.
Yes.
So let's get started with presentation mode. My topic is COVID-19 at high altitude, global health perspective from Nepal. I'll try to give a broad perspective and the numerous myths and confounders in high altitude area with COVID-19. Without further ado, and I would like to acknowledge first and also declare that there is no conflict of interest, financial or other disclaimers to declare. Brief overview. Once this pandemic started, SARS coronavirus 2 or COVID-19 coronavirus disease 2019, it just spread globally and took a pandemic mode, and national and international tourism travel restrictions affected a lot of movements and mobility. And then there were rumors that people were making up, and some emergency physicians were telling that, or other people as well, speculating that COVID-19 lung injury or pneumonia or ARDS they call is similar to the hypoxia that people suffer when they go at high altitude or suffer from lung injury, high altitude, pulmonary edema at altitude. Then next rumor or that evidence emerged that high altitude residents who are genetically adapted, like Tibetans and Sherpas and others, are not so affected with SARS-CoV-2. And this sort of all progress or the development in the field has affected climbing, trekking, mountain sports, and also high altitude pilgrimages. And there is RC Gumba collection activities in Nepal that has a huge economic impact, and the mountainous regions that is also affected. And how this has affected in a health and economy of the locals with the international travel bans, that will be briefly previewed in this presentation. Just a brief overview. Please feel free to stop me and ask questions if you feel so, or panels allow. That's totally fine. Just to give an overview that people, there are lots of ranges around the world. There is Rocky Mountain in North America, and Andes in South America, and the huge range of mountain range. Similarly, Alps altitude in Europe, which is more accessible due to development of new transportation techniques and technology like gondola and train passing through the high passes. And also Himalayas, Hindu Kush, Karakoram, and Himalayan range in our part of the world, Asia, is a big one. And then there is also Ranjori Mountains and the Ethiopian Highlanders. So there are big high altitude regions where people stay and have generations left, centuries live there and adapted. Just brief overview what happens when you go at altitude, because I'm talking about altitude. When you go at a altitude, the barometric pressure that falls linearly down. The percentage of oxygen, FiO2, which we call in science, is same, but the pressure is decreased. As pressure decreases like this, and as you go altitude, and then the pressure above you is less. That less pressure on the right panel, you can see far right panel, is leads to less oxygen availability to you in the blood. So when you go at altitude, whether you suffer from altitude sickness or other sickness or not, you have naturally less oxygen and you have to live with that. And some of the people who are acutely exposed, that newly arrived from lowland or lowland dwelling, born and raised at lowland, might suffer some of the fatal illnesses. Some of the important illnesses that offer is water in the lung, which we call high altitude pulmonary edema. And another is water in the brain, that is we call that high altitude cerebral edema. These are very fatal conditions, and people can die if we don't take steps. So of course, the first step is to give oxygen, because they don't have oxygen unless they have a lot less oxygen. Or the best is to remove altitude, come down or evacuate. And then kidney is also affected, because kidney works pathophysiologically to correct that less oxygen. This hyperbaric hypoxia and some of the atypical lung injury that is not very typical presentations seemed like high altitude hypoxia. Were they so? So there were some publications from some others like Slimandis and Cameron Carl series and also thoracic medicine, and also some of these social medias. They were just spreading rapidly that notion that this looks like a high altitude hypoxia. Then we sort of examined whether there is similarity in pathophysiological basis, and actually that it didn't make sense pathophysiologically, and more intense tease out were there. And Burger et al. Also tried to tease out the exact differences between the compare and contrast. And then Strapazon et al. Also tried to look into the type of COVID-19 lung injury patterns and their modalities. And some of the atypical lung injuries were, in fact, were coming to the emergency or ICU. They were not gasping for the air. They were not, naturally, when you don't get oxygen, you have to gasping and you have to be like very panicking. And these patterns in COVID-19, which are atypical, were not so like that. So it led to sort of a point of term in science about happy hypoxia. They are just happy, they are just okay, but they are very low in oxygen content in the blood. So why is it happening? We don't know yet. There are a number of pathophysiological purposes. And Steve Archer et al. And Tobin et al. They have sort of tried to tackle with this baffling hypoxemia. And if there is any avenues of research with altitude field, because it's such a natural exposure and people are happy to get exposed to extreme altitude with extreme hypoxia, and what happens if we do that? So there might be some opportunities for that, but they don't look similar. Then why does that high altitude residence? So when I talk high altitude residence, I'm talking about people who are living for centuries, who are born and raised at a high altitude, like Tibetans, Sherpas, Indians, and Kyrgyz Highlanders, and the people who live in Ethiopian highlands. They are genetically adopted. And also there are people who are going to trekking, climbing, and pilgrimage and other mountain sports that has effect in the altitude and economy. And there are mining industries in South America and Kyrgyz highlands. And on top of that, for me, is natural laboratory. We can do a lot of scientific experiments and learn those cues to apply other health conditions. So how does that COVID-19 and SARS-CoV affect to this altitude residence? We talked about recent acute exposure altitude illnesses. Now, there are recent epidemiological observations that suggest that there is a lower incidence and also very slow or less community transmission at altitude, and also less mortality among high altitude residents. There could be multiple factors responsible for this, but is there some pathophysiological basis or adaptation due to living at high altitude? So this small study from China came that Qinghai Plateau, Jining province, that there was no sustained community local transmission, decreased virulence at altitude, came from the observations done with the data from Tibet, Bolivia, and Ecuador compared with the lowlanders. And then there was again a Peruvian data shows that there was a less frequent and at altitude COVID-19, and there is also decreased incidence recent with case fatality, but overall incidence not case fatality. So overall incidence was less, but case fatality was not. So this again, the sustained data keep coming from South America. So this publication particularly get a lot of attention. You can see Washington Post, Miami Herald, and also Times of India and News Medical. They picked up so fast that, oh, okay, that high altitude residents are protected. But yeah, are they? We have to examine. And our vernacular local newspapers in Kathmandu also were very quick to write a long page on this and also make a YouTube video and showing the picture of Namche Bazaar, that if you are living in Namche Bazaar, you are okay. Is that so? We need to examine. So we try to explore and facts and confounders in the field, and there is not really the pathophysiological basis of that. The evidence that the mechanism that virus uses angiotensin receptor 2 mechanism to enter into the cell, they had proposed that it is downregulated, but there is no human data. And there is only animal and cell culture studies, and that is also very acute exposure. There might be environmental factors, high ultraviolet radiation, dry and cold, and vitamin D with higher UV rays. But they are very, very fringe evidences. There might be, or there might not be. And there is a desiccation with higher UV and less water content and high humidity at altitude that might inactivate virus, and lower air pollution at altitude naturally. These are very, very speculative and very subjective sort of nature that very hard to teach out. And then there is social structure. Naturally, it is remote. Physical distancing is possible because of sparse population, and population group is relatively young, and maybe this is early lockdown measures had helped to not to virus spread there. So this transportation facility as well. Sorry. So lower incidence of altitude. So far, there is no evidence. Environmental and social other factors might be playing. There is insufficient data to support this. And actually, there is recent study says that higher incidence and higher mortality above 2,000 meter altitude is data from US and Mexico. So that has, COVID-19 has impacted Himalayas quite a bit. These trekkings and all these mountain sports have been completely shut down. The Pilgrims Health Camp has been shut down. Arsakumba collection has been shut down. The Ferisi Clinic was shut down. Manang Clinic. Similarly, Everest Base Camp Clinic and climbing activity was canceled. Field studies are not there. And similarly, health camp, as I said. And global to local impact. Why does it impact? That those health camps that are high altitude medical aid posts conducted by Himalayan rescue associations, they are staffed by volunteer physicians, and they raise revenues. They charge international trekkers, they serve locals, and they serve at a free, and they serve the porters, the poor porters, poor of the poorest, free, and the money raised from there is used to have a free health camp in other parts of the Nepal, like pilgrims, Arsakumba collectors, and also there is quite a bit of development, mountain rescue and source in Nepal, like a diploma in mountain medicine. So this has all been affected, and if you look at, all right. Yeah. So, okay. So that's the last slide. And in summary, there is no evidence that high altitude residents are protected, and we need to just use the usual methods of prevention. Thank you.
Thank you very much for the talk. I'm Dr. Kush from Australia. I'll request the next speaker, Mr. Pranav Mehta, to come and give us his talk, please. He's an undergraduate student at Rice University, Houston, Texas. He's studying cognitive neuroscience and health science on the pre-medical track. You have 10 minutes and I'll give you a warning at around 8 minutes. Thank you very much.
Yes, 1 second. Okay, first and foremost, I'd like to thank everyone for giving me an opportunity to present my research. All the presentations so far have been fantastic, and I'm looking forward to sharing my work. So first off, my name is Pranav Mehta, and I'm a sophomore at Rice University. In partnership with the Federation of Jain Associations in North America, our research group, consisting of myself, Sneh Shah, Morris Shah, and Dr. Nitin Shah, will be discussing the correlation of diabetes, heart disease, and COVID-19 in Indian Jain populations across the United States of America. To share some background on what motivated our research project, after reviewing a meta-analysis, we found that diabetes rates have significantly increased in all urban and rural populations of Nepal from 2000 to 2014. Interestingly, we also found that Nepal also has approximately 6 million Indian Asians, and of these Indian Asians, the ones with diabetes are largest at risk for developing cardiovascular disease, also noted as CVD. This potential presence of having two conditions at the same time is known as comorbidity and can severely increase the likelihood for infections such as COVID-19. Though interesting, research does not currently show how the comorbid conditions affect specific subgroups of Indians in Nepal, such as Jain populations. This recognition led us towards the creation of our broad research idea. The basis behind our research was to determine the correlation between COVID-19 and specific comorbidities in Indian Jain populations in the United States. According to the 2011 Nepalese census, there are approximately 3,200 Jains that live in Nepal. However, there's no current research on their COVID-19 incidence rates. The same applies for Jains in the United States. This lack of research has created limitations in public health interventions that can ensure safety to a larger group of Nepal natives during the pandemic. Given that Jain Indians in America can be considered similar to Jain Indians in Nepal due to similar cultural practices, dietary decisions, understanding the association between diabetes and CVD and COVID-19 will be beneficial in creating more preventative methods for safety. More so, increasing public health awareness for these methods will be critical in helping minimize the mortality and morbidity rate in Nepal during the pandemic. So overall in our study, we predicted that the Indian Jains with diabetes and cardiovascular disease will have a higher likelihood of testing positive for COVID-19. Before discussing our survey, we want to discuss the conditions that we will be assessing. The first condition is diabetes. Many of you are familiar with it. Just to recap, diabetes is a chronic condition associated with abnormally high levels of sugar in the blood that can lead to very dangerous complications such as heart disease, nerve pain, and eye damage. Among all ethnic groups, Asian Indians are found to have some of the highest rates of pre-diabetes and diabetes due to several cultural factors, sedentary lifestyles, obesity rates, as well as high fat and high calorie diets. Individuals with diabetes have an increased likelihood of contracting cardiovascular disease, or CVD. And CVD refers to the complications related to the heart and blood vessels, such as coronary heart disease and hypertension. According to research, South Asian populations are found to be at almost 4-fold higher risk of obtaining CVD than general populations because of their diabetes, high blood pressure, obesity rates, and high cholesterol diets. On a molecular scale, these are a few of the several factors that can lead to greater pressure on both the cardiovascular and respiratory systems when supplying oxygen-rich blood to organs, and can eventually cause individuals to become more susceptible to infection transmission. And lastly, the infection that we're going to be focusing on is COVID-19. COVID-19, as mentioned in previous presentations, is a respiratory illness caused by the SARS-CoV-2 strain that can spread from person to person. As of September 18th, 2020, yesterday, There have been 30.5 million reported cases of COVID-19 and 952,000 deaths. Many details about the virus are still unknown, such as treatment options, how the virus works, and the total impact of the illness. However, as per current date, we know that people of all ages and backgrounds can be infected, specifically older adults, and that individuals with pre-existing medical conditions like asthma, diabetes, and heart disease are more likely to become severely ill if infected. Yes. So now that we reviewed the molecular and global interactions of diabetes and CVD with COVID, I will discuss how this can be relevant in Jain populations. Jain populations practice the religion of Jainism, which was established in 500 BC in eastern India. Currently, there are approximately 6 million Jains worldwide, 150,000 in America, and around 3,200 in Nepal. Jains strongly believe in practicing a vegetarian diet, and according to literature, have a high incidence of cardiovascular disease and diabetes. Understanding their religious influence on dietary lifestyle and disease commonalities gives us an extensive background on our focus group. Now, to set up our research, we conducted a standardized Google Forms survey across Jain populations in the United States of America with the help of partner organizations such as Jaina and the YJA. In the survey, we asked 17 short questions ranging from the participant SES, genetic predispositions of diabetes, CVD, cancer, asthma, their dietary lifestyle, whether they're vegetarian, vegan, complete Jain diet, and their incidence of COVID-19, their history. Based on the responses, we assessed for the relationship of diabetes, CVD, and COVID-19 with each other. After 3 months, we had a total of 817 subjects participate in the survey. From the 817 subjects, 13% had tested positive for COVID-19 in the past or at the time of the survey, as shown in Figure 1. In Figure 2, we see that of the Jains who had tested positive for COVID, 52% had diabetes or a genetic predisposition for diabetes in their family. Then in Figure 3, we can see that 75% of the Jains who tested positive for COVID-19 with diabetes also had cardiovascular disease or a genetic predisposition for CVD in their family. From our background research, we were able to initially understand that CVD and diabetes are, of course, chronic illnesses that are interconnected with each other and cause severe damage to the body. And beyond that, populations comorbid with diabetes and CVD tend to have an increased likelihood for contracting infections such as COVID. And now through our survey, we're able to determine an evident correlation between the comorbid state and the incidence of COVID-19 in US Jain populations. In other words, our findings suggest that Jains in the United States with CVD and diabetes are more likely to test positive for COVID-19, thus proving our hypothesis correct. These results give us new insight onto the influence that COVID-19 infection has on Jain populations, and therefore, this study can be replicated to further understand the implication of COVID on Indian Jain populations in Nepal, who suffer from similar concomitants. Even though our findings provided us with plenty of insight into the US Jain community, moving forward, there are still plenty of factors that we can strengthen based off of our current results. Given that we were based on self-reported data without proof of medical history, we had a small sample size of around 817 subjects, and the results were gathered without a baseline survey. Nonetheless, our research provides us plenty of new ideas and strategies for preventative measures which can ensure better health and safety of Indian populations in Nepal, especially those under the Jain subgroup. Since 2017, CVD has contributed to over 27% of all deaths in Nepal, and rates have constantly increased since then. Therefore, we need to implement more awareness and educational campaigns for preventative measures.
You got 2 minutes left, thanks.
We need to implement more awareness and educational campaigns for preventative measures which can decrease the rates of diabetes and CVD in both Jain and Indian communities in Nepal. And as CVD continues to grow within these Nepalese populations, we need to also strengthen regulations on foods rich in salt, fat, and cholesterol, all which contribute to heart disease. And simultaneously, we should increase funding for exercise programs accessible to the community. Likewise, to provide greater accessibility and empower low-income populations, Nepal should continue strengthening their integration of telemedicine and artificial intelligence in all community centers to make education and healthcare accessible, cheaper, and faster. Additionally, studies have shown that due to quarantine and social distancing guidelines, individuals comorbid with CVD and diabetes are likely to have poor dietary lifestyles, all of which are combined to have higher rates of mental illness. We as a community need to continue motivating local grassroots organizations to lead initiatives which can address the mental health of communities at risk. With support from the community and greater education on factors at risk, we may not be able to cure COVID-19 completely, but we will definitely be able to foster a healthier community together through the pandemic. Thank you so much. And if there's any time, I can answer any questions, but I believe we're answering it at the end.
Yeah, thank you.
Yeah.
Yeah, that's correct. Yeah.
Okay, thank you so much.
We'll request the next speakers, Mr. Rajan Shrestha and Prashant Paudel. Who is presenting here? Is it Prashant Paudel? He's currently working as a fellow in otolaryngology, head and neck surgery for past 3.5 years at TUTH, Institute of Medicine. And he's got an MBBS from Maharajganj Medical Campus. He's got diploma in global health from University of Tampere, Finland, and having work experience in about a dozen of national and international organizations, including project coordinator for BPI Foundation. Dr. Prashant Paudel, to you.
Yeah, thank you. I think I'll request Rajan Shrestha sir to, because we both are presenting the same topic.
Okay, all right. Sure.
You could just introduce briefly on Rajan Shrestha. So
okay, Rajan Shrestha is working as a research officer at BPI Foundation, Hospital for Children Eye, ENT and Rehabilitation Service, Bhattara, Nepal, completed Masters in Health Promotion and Education from Institute of Medicine, Prevalence University, Nepal. Thank you, Mr. Rajan. Thanks.
Thank you, Dr. Kush. Namaste, everyone. I am Rajan Shrestha from BPI Foundation, Hospital for Children, IENT and Rehabilitation Services. I'm here with the topic anxiety, depression, and functional impairment during COVID-19 pandemic among healthcare workers across sectional online survey. We are 5 in a study team, me, Rajan Shrestha, Vijay Khatri, Suman Ranjitkar, Santoshi Adhikari, and Dr. Prashant Paudel. We have no conflict of interest. In background, COVID-19 रोग चाहिँ नि यो कोरोना भन्ने भाइरसले गर्दाखेरि अहिले विश्वभर एकदमै र्यापिडली बढिरहेको रोग छ र 28 अगस्त 2020 सम्ममा यो रोग लागेर प्रसिद्ध भएको more than 24 million confirmed cases छन् भने more than 82700 death globally report भएको छ र यो सिचुएसन चाहिँ एकदमै स्ट्रेसफुल हुनुको कारणमा चाहिँ यो कहिले कन्ट्रोल हुन्छ यसको भ्याक्सिन कहिले बन्छ भन्ने कुरा अन्यलमै भएको भएर यसले अझै स्ट्रेसहरू बढाएको छ र यो डिसअर्डर यो पेन्डेमिक सुरु हुनुभन्दा अगाडि नेपालमा गरिएको सर्वेक्षणमा झन्डै 13% मानिसहरुमा चाहिँ मेन्टल डिसअर्डर रहेको देखिएको छ र यस्तो पेन्डेमिकहरु म्यानेजमेन्ट गर्ने क्रममा चाहिँ हेल्थ वर्करहरुलाई र अरूहरुलाई पनि मेन्टल हेल्थ प्रब्लम चाहिँ एकदमै देखिएको छ तर देखिए तापनि मेन्टल हेल्थ चाहिँ एकदमै नेग्लेक्टेड फिल्ड रहेको छ र हेल्थ केयर वर्कर्सहरुमा चाहिँ यो खालको पेन्डेमिकमा साइकोलोजिकल एज वेल एज फंक्शनल इम्पेयरमेन्टको समस्याहरू पनि देखिएको पाइएको छ हाम्रो स्टडीको अब्जेक्टिभ चाहिँ टु डिटरमिन द बर्डन अफ एन्जाइटी डिप्रेसन एन्ड फंक्शनल इम्पेयरमेन्ट ड्युरिङ कोभिड-19 among health care workers of tertiary level IENT hospital in Bhattara, Nepal रहेको छ हामीले यो स्टडी मा चाहिँ हस्पिटल बेस्ड डिस्क्रिप्टिभ क्रस सेक्सनल स्टडी डिजाइन युज गरेका थियौं जुन चाहिँ हस्पिटल फर IENT हस्पिटल फर चिल्ड्रेन IENT एन्ड रिहेबिलिटेसन सर्भिसेस लोकन्थली भक्तपुरमा गरिएको स्टडी हो यसमा हामीले त्यो हस्पिटलको सबै स्टाफहरुलाई हामीले इनरोल गरेका थियौं र हामीले डेटा कलेक्सन चाहिँ 3 अप्रिल देखि 2 मे जुन चाहिँ नेपालमा नेसनवाइड लकडाउन भएको सेकेन्ड विकबाट हामीले स्टार्ट गरेका हौं यसमा टोटल स्याम्पल साइज 86 रहेको छ र डेटा कलेक्सन गर्दाखेरि हामीले यसमा सेल्फ एडमिनिस्टर्ड क्वेशनर जुन चाहिँ गुगल फर्ममा हामीले कलेक्सन गरेको हो त्यो हामीले इमेलबाट प्लस फेसबुक मेसेन्जरबाट हामीले डेटाहरु कलेक्सन गरेका थियौं यसमा युज गरेको टुल चाहिँ नेपाली भर्सन अफ 14 आइटम हस्पिटल एन्जाइटी एन्ड डिप्रेसन स्केल हो जुन चाहिँ HEDS-A एन्जाइटी को लागि र HEDS-D डिप्रेसन को लागि युज हुने टुल हो जुन चाहिँ 0 to 3 रेटिङ स्केलमा थियो र अर्को फङ्सनल इम्पेयरमेन्टको लागि हामीले युज गरेको टुल भनेको नेपाली भर्सन अफ 12 आइटम WHO डिसेबिलिटी एसेसमेन्ट स्केल हो, जुन चाहिँ 0 to 2 रेटिङ स्केलमा रहेको थियो। पार्टिसिपेन्ट जसको चाहिँ नि HEDS A स्कोर मोर देन अर इक्वल टु 11 भएकोलाई हामीले एन्जाइटी भएको भनेर क्लासिफिकेसन गरेका छौँ भने HEDS D टोटल स्कोर चाहिँ मोर देन 11 or इक्वल टु 11 भएकोलाई चाहिँ हामीले डिप्रेसन भएको भनेर क्लासिफाई गरेका छौँ। अब यो टुलहरूको हामीले इन्टरनल कन्सिस्टेन्सी क्याल्कुलेट गर्दाखेरि तीनवटै टुलको चाहिँ मोर देन 0.8 क्रोनबेक अल्फा आएको छ, जुन चाहिँ एकदमै राम्रो भनेर मानिन्छ। अब रिजल्ट पार्टदेखि चाहिँ डाक्टर प्रशान्तलाई प्रेजेन्ट गर्न आग्रह गर्दछु। डाक्टर प्रशान्त प्लिज।
धन्यवाद राजन सर। र म अलि नेपालीमै बोल्न चाहन्छु, किनभने यो अङ्ग्रेजीमै भएर पनि सबै दर्शकहरूको लागि र नेपालीहरूको लागि यो हिस्ट्री भएको हुनाले र हाम्रो गरेको रिजल्ट अनुसारमा चाहिँ अब केही फाइन्डिङ्सहरू सेयर गर्नु पर्दाखेरि चाहिँ महिला र पुरुष बराबर नै जस्तो छ, त्यही भएर चाहिँ जेन्डर बायस अलिकति कम नै गर्न खोजेका छौँ। लक्कीली पनि त्यो भयो। एजमा चाहिँ अलिक एज पुगेको मान्छेहरू अलि भन्दा कम एजको मान्छेहरू, किनभने अब यङ एक्टिभ मोर देन चाहिँ भर्खरै पास हुनुभएकोहरू चाहिँ रिसेन्टली जब इम्प्लोइमेन्टमा हुनुभएर पनि देखिएछ। अनि इम्प्लोइमा चाहिँ नट ओन्ली द क्लिनिसियन बट एज वेल एज द क्लिनिसियन होइन, नन क्लिनिकल स्टाफ्सहरू पनि इक्वली इम्पोर्टेन्ट छ। हाम्रो निर्मला श्रेष्ठ म्यामले चाहिँ रिसेन्टली फर्स्टमा प्रेजेन्ट गर्दाखेरि चाहिँ हेल्थ वर्कर्स भन्नुभयो, तर आई थिङ्क स्टाफहरू पनि एपार्ट फ्रम द डक्टर्स र नर्सेसहरूलाई पनि हामीले इक्वली काउन्ट गर्नुपर्छ होला। अर्को स्लाइडमा जानुहोस् त। र म धेरै जस्तो स्टडी पपुलेसन चाहिँ म्यारिड नै हुनुहुन्थ्यो 66%, र म्याक्सिमम् यसमा चाहिँ परिवारसँगै बस्नुभएको थियो, किनभने हाम्रो नेपालमा चाहिँ मोस्टली अहिले पनि जोइन्ट फ्यामिली नै छ। सोसियो कल्चरल एस्पेक्ट हुने पनि हो होइन, यो कोभिडको अब हामीलाई डर भएको कारण चाहिँ एउटा त्यो पनि हो। अर्को चाहिँ अब घरमा जोइन्ट फ्यामिली हुने बित्तिकै चिल्ड्रेन र एडल्टी हुने त बढी नै देखिन्छ। हाम्रोमा पनि त्यही नै छ 70%। र हिस्ट्री अफ फरेन ट्राभल चाहिँ अलिक किन रिलेभेन्ट छ भने एराउन्ड हामीले स्टार्ट गरेको अप्रिलमा, त्यो बेलामा WHO देखि वर्ल्डभरि नै नेपालमा चाहिँ अलि राम्रो तरिका अपनाउनु भएको छ, फैलिएको छैन भन्ने थियो होइन। र वेदर इट इज विदिन द कम्युनिटी अर एक्चुअली कमिङ विदिन द फ्रम आउटसाइड द बोर्डर भन्ने हिसाबमा हो। तर त्यो बेलामा धेरै फरेन ट्राभल चाहिँ हाम्रोमा चाहिँ स्टडीमा चाहिँ देखिएन होइन। फ्यामिली मेम्बर विथ क्रोनिक डिजिज भन्नाले यहाँ डायबिटिज, हाइपरटेन्सन, कार्डियक डिजिज अघि पनि कुरा गर्नुभयो इम्पोर्टेन्ट, त्यस्तै आस्मा होइन, किडनी डिजिज, यी क्यान्सर पनि। हामीले क्यान्सर भएको बिरामीलाई पनि अब एकदम छुटाउनु होइन, किनभने उहाँहरूले चाहिँ दे सुड नट बी डिलेड ट्रिटमेन्ट बिकज अफ कोभिड है। र अर्को चाहिँ कफ, सोर थ्रोट, कमन कोल्ड, जुन चाहिँ अब विभिन्न खालका लक्षण भने होइन, तर कोभिडले चाहिँ कुनै पनि सिस्टम शरीरकोलाई छोडेको छैन। इट्स नट ओन्ली कफ, सोर थ्रोट अर कमन कोल्ड, तर अब यो धेरैलाई लागेको छैन नै भन्ने जस्तो थियो। हाम्रो अरू स्टडीसँग मिल्न आउँछ। र धेरैलाई यो अलि एङ्सियस हुने होइन, आत्तिने किसिमको समस्या र यो एकदम दिक्क लाग्ने जस्तो समस्या, डिप्रेसन जुन छ अलिक बढी नै देखिया छ। तर त्यसमा पनि बढी आत्तिने चाहिँ समस्या, किनभने हेल्थ वर्कर अब क्लिनिसियन हस्पिटलमा चाहिँ हामीले चाहिँ बिदा बस्न पाउँदैनौँ। हामीले चाहिँ कन्टिन्युस वर्क गरिरहेको थियौँ इभन एमङ द पेन्डेमिक होइन। त्यो कारणले तर चाहिँ कस्तो होला, हामीलाई लाग्ला कि नलाग्ला भन्ने हिसाबमा पनि देखि अलि हाई नै छ पर्सेन्टेज मेन्टल हेल्थ। नेक्स्ट, किनभने हामी बढी फिजिकल हेल्थमा मात्र अलिक फोकस भयौँ जस्तो लाग्छ मलाई यो कोभिड-19ले। अनि अर्को जेन्डर चाहिँ अब हाम्रोमा यो गरेको विभिन्न स्ट्याटिस्टिक भ्यालु हो। अब यसमा मैले मेन जिस्ट भन्छु। जेन्डरमा चाहिँ फिमेलहरूलाई चाहिँ फिमेल पपुलेसनमा चाहिँ एङ्जाइटी अलि र डिप्रेसन दुइटै बढी देखिएको छ। सायद त्यो चाहिँ अब अर्को जेनेटिक फ्याक्टर हुनसक्छ, अर मेबी इट इज किन बढी देखेको छ भन्ने एउटा अर्को रिसर्च क्वेसन हुनसक्छ। यसमा हामीले रिसर्च गर्न सक्छौँ होला, मेबी अदर फ्याक्टर एज वेल, नट ओन्ली द जेनेटिक फ्याक्टर। अर्को एज फ्याक्टर पनि अलि बढी उमेर भएकोहरूलाई चाहिँ बढी एङ्सियस र डिप्रेसन। अब यसमा चाहिँ अलिकति मिडियाको रोलहरू पनि छ। हामी अब सबैले चाहिँ गएर आई थिङ्क यो स्टडी चाहिँ भइ नै रहेको छ, तर होइन अब आज कति आए, कतिवटा आर्टिकलहरू रिट्र्याक्टेड पनि भए। सो कुनै पनि कुरा अब हामीले आई थिङ्क पब्लिस गर्नुभन्दा अगाडि चाहिँ अलि एउटा साइन्टिफिक सिस्टमिकबाट गरेर मात्र जेनरल पपुलेसनमा चाहिँ ल्याउनुपर्छ होला। बिकज मिडियाको पनि धेरै रोल हुन्छ, आइदर इट इज साइन्टिफिक अर इट्स थ्रु द मिडिया। अर्को चाहिँ इम्प्लोइ टाइपमा चाहिँ इम्प्लोइ टाइपमा चाहिँ गएर क्लिनिकल्सहरूमा अलिक बढी देखिएको छ। नेक्स्ट त्यस्तै अब म्यारिडहरूमा चाहिँ अलि बढी एङ्सियस र डिप्रेसन हुने चाहिँ समस्या त भइ नै हाल्यो, किनभने आफ्नो पार्टनरमा पनि उहाँहरूले सार्न सक्नुहुन्छ कि भन्ने एउटा चिन्ता हुन्छ। र घरमा बालबच्चा र वयस्क भएको ठाउँमा चाहिँ पनि बढी नै एङ्सियस र डिप्रेसन देखिएको छ। नेक्स्ट छ फरेन ट्राभल हिस्ट्री चाहिँ बढी भएकोमा बढी एङ्सियस डिप्रेसन। त्यस्तै क्रोनिक डिजिज बढी भएकोमा चाहिँ भन्दा पनि नभएकोमा पनि डिप्रेसन देखिएको छ होइन। अब यसको अरू सर्टेन फ्याक्टर्स पनि हुन सक्छन्, नट ओन्ली द क्रोनिक डिजिज हुँदैमा चाहिँ एङ्सियस हुने भन्ने होइन, क्रोनिक डिजिज आफैले पनि एङ्जाइटी ल्याउन सक्छ। अर्को चाहिँ कफ, सोर थ्रोट, कमन कोल्ड भएका भन्दा नभएकालाई चाहिँ बढी अब मलाई भएको छैन कस्तो होला के होला भन्ने जस्तो अर्को एउटा फ्याक्टरले गर्दा पनि होला। नेक्स्ट अब हामीले मिन निकालेको छौँ, मिन चाहिँ एङ्जाइटी स्कोरको चाहिँ 7.27, डिप्रेसनको 5.13 र फङ्सनल इम्पेयरमेन्टको 19.47 चाहिँ स्कोर निस्केको छ। र यो अड्स रेसियोमा चाहिँ फिमेलमा चाहिँ 5 टाइम्स बढी एङ्सियस देखिनु भएको छ। त्यस्तै डिप्रेसन पनि ट्वाइस। म्यारिडमा चाहिँ 4 टाइम्स बढी देखिएको छ। त्यस्तै डिप्रेसन पनि म्यारिडहरूमा चाहिँ 2 टाइम्स। यो सबै कोभिड रिलेटेड हो। नेक्स्ट र यो एङ्जाइटी स्कोर लेस देन 11 भएको, जसलाई चाहिँ एङ्जाइटी भएको छैन उनीहरूलाई भन्दा यो स्कोर बढी भएको र एङ्जाइटी बढी भएकोलाई चाहिँ फङ्सनल इम्पेयरमेन्ट अलिकति बढी नै देखिएको छ। सिमिलरली डिप्रेसनमा पनि अब यो दुइटै फ्याक्टर मेन्टल हेल्थले गर्दा छ, फङ्सनल इम्पेयरमेन्टमा अलिकति फरक चाहिँ पार्दो रहेछ उहाँहरूले काम गर्ने शैलीमा भन्ने देखिएको छ। नेक्स्ट अब कन्क्लुजनमा के भन्दाखेरि कोभिड-19 पेन्डेमिक चाहिँ मा चाहिँ मेन्टल हेल्थ इस्युज पनि इक्वली इम्पोर्टेन्ट छ। आजको स्टार्टिङ ओपनिङ सेरेमनीमा नि डेफिनेसन अफ हेल्थ वर्ल्ड हेल्थ एसेम्बली दिनुभएकोमा फिजिकल, मेन्टल र सोसियल वेलबिङ होइन, हामीले चाहिँ सबै पार्टलाई चाहिँ इक्वली इम्पोर्टेन्ट कोलाबोरेट गरेर जानुपर्छ होला। तर अब विदाउट कजिङ सिग्निफिकेन्ट फङ्सनल इम्पेयरमेन्ट भनेको अहिले चाहिँ हामीले चाहिँ जुन फ्रन्टलाइन हिरो
टाइम सक्यो है, अब ऱ्याप अप गरौँ।
ओके, म ऱ्याप अप गर्छु। हामीले चाहिँ गएर उहाँहरूले चाहिँ आफ्नो काममा चाहिँ कुनै पनि बाधा पार्नु भएको छैन, सबै चाहिँ निरन्तरता दिइराख्नु भएको छ होइन। हाम्रो यो स्टडीले चाहिँ हामीले मेसेज के दिन खोजेको हो भन्दा यति इट्स अलरेडी 9 मन्थ होइन। म टिचिङ हस्पिटल नेपालको सबैभन्दा टर्सरी सेन्टरमा काम गर्छु एज अ ओटोराइनोल्यारिङ्गोलोजिस्ट, जुन चाहिँ कोभिडको लागि नम्बर 1 हाइली चाहिँ डेन्जरस भनिन्छ इन्फेक्सन हुने हाई रेट। स्ट्रेस म्यानेजमेन्ट प्रोग्राम चाहिँ अलिक फोकस भएको छैन। त्यही भएर आई थिङ्क दिस इज अ अपर्च्युनिटी फर टिम लाइक अस एन्ड अर्गनाइजेसन लाइक एनआरएन। हामीले यस्तो केही एउटा चाहिँ प्रोग्राम ल्याउन सक्यो भने यसको चाहिँ औचित्य ठिक हुन्छ होला। र यो चाहिँ मल्टी सेन्टर स्टडीमा पनि गर्न सकिन्छ, बिकज यसमा चाहिँ हामीले अनलाइन त्यहीँ गएर डाटा कलेक्सन गर्नु पर्दैन, गुगल सिट अनलाइनबाट गर्न सकिन्छ। सो यो दुईवटा चाहिँ मेरो रिक्वेस्ट छ एनआरएन टिमसँग टु प्लिज काइन्डली थिङ्क अबाउट इट। थ्याङ्क यू।
Thank you. Dr. Sakti, you got someone else presenting?
I think I'm presenting now. It's me, right?
हजुर, डाक्टर विष्णु तपाईँ गर्नुभयो हुन्छ, उहाँ तपाईँ पछि गर्नुहुन्छ, उहाँ अहिले
Namaste and good morning, everyone. I'm Dr. Vishnu Sapkota. Can you see the screen?
Yes, thank you.
Okay, let me kind of get the full screen. Okay. I'm Dr. Vishnu Sapkota. I'm the Secretary of American Nepal Medical Foundation, and I'm the practicing gastroenterologist here in the United States. The topic of my talk today is COVID-19 pandemic and role of ANMF in fighting the pandemic in Nepal. For a disclosure, I have to say that my presentation is not based on rigorous scientific methods, because ANMF use a holistic approach to fight the pandemic in Nepal before the onset of pandemic that actually touched Nepal. But I think this talk is relevant because the measures we use to catalyze the nation initially to fight the pandemic. And I would like to thank NRNA in providing this platform for me to talk. So as of today, we have more than 62,000 cases in Nepal, active and recovered, and more than 400 people have died in Nepal, and the number is increasing. ANMF acted proactively before the COVID-19 pandemic hit Nepal. We used all hands on deck on March 13, 2020, because we knew the impact of COVID-19 pandemic in a resource-limited country like Nepal could be devastating. As you know, on March 14, 2020, the first lockdown in Nepal happened. Just to give you the perspective, what was the situation in ground at that time, one of our president of American Nepal Medical Foundation from Nepal wrote an email, and I have a little summary of that email to you. And he writes, everybody is worried about what will happen, especially healthcare personnel are at risk. They are working, but not enough precautions and PPE. Even the simple mask is not available enough. I would like to request ANMF board to work towards corona prevention action. This is copied. So in mitigating the pandemic, American Nepal Medical Foundation from the onset worked on all aspects of mitigating pandemic. We use a common sense, holistic approach. We mobilize our diverse physician and non-physician resources, including financial resources. We collaborated with healthcare institutions and like-minded organizations in Nepal early on. So basically, what we did was we created the task force, then we did collaboration with like-minded organizations. We did awareness program via webinars using social media, workforce training in Nepal in collaboration with other organizations in Nepal. We distributed PPE in all provinces in Nepal. We also established a mental health desk. We conducted webinars on mental health in collaboration with Psychiatrists Association of Nepal. We worked on quarantine and isolation. We worked on diagnostic. So we basically wanted to approach this pandemic from all areas. So in the initial days that I'm talking about March of 2020, before a first case was seen in Nepal, we did few things. And this cartoon basically presents some of those few things we did. In collaboration with Nepal Medical Association, we conducted 6 days online sessions for all the healthcare workers from all around Nepal for prevention and management of COVID-19. Remember, that time the fear was so much in the mindset of healthcare provider, as our previous speaker have already mentioned, and we wanted to alleviate that fear to some extent by knowledge sharing. We also collaborated with NCCDF, and what we did here was we basically conducted workshops in what is the best infection control practices, how to wear personal protective equipments appropriately, and many other areas. We conducted more than 25 webinars, and these webinars included topic of all aspects of COVID-19, including mental and physical well-being of healthcare providers. We invited specialists from Nepal and specialists from United States who had first-hand experiences so that knowledge could be shared. And the whole idea was to give some kind of confidence in the healthcare provider in Nepal when they are taking care of those patients. We collaborated with National Innovation Center in basically making all these sample collection booths, aerosol devices during taking care of this patient, including intubations, local production of PPE, and many other areas. We also, initial part of the days, when there was uncertainty how to collect and transfer the samples, we basically rented a vehicle that would transfer the sample from different hospital to national laboratory. We created a fever clinic in collaboration with Iowa Institutes of Medicine that would provide telemedicine remotely to the needed patients. We worked with Ox Foundation that provided platform for us so that our specialists here can talk with the specialists outside the Kathmandu Valley in different hospitals in care coordinations, basically exchange of ideas and knowledge in taking care of difficult patients. So we funded isolation center in Birgans for the human resource support because their local hospital did not have capacity to manage the source of the patients. And we also worked in monitoring and management of pregnant postpartum mothers and children in quarantine and isolations. We work with Nepal Health Research Council in therapeutics areas. So basically what we did is we spent more than $122,000 in different areas, and some of those areas already have been brought up by our previous speakers. So as this was not a rigorous scientific study, so the results are difficult to measure. However, we think that early training and education on infection control practices and distribution of PPE in initial days of pandemic helped boost the morale and confidence among healthcare workers in Nepal. Patients and providers benefited from telemedicine and teleconsultation and its ongoing effort. Working with Nepal Medical Council, we were able to formulate initial guidelines on COVID-19 management, which has been endorsed by Ministry of Health, Nepal. And knowledge sharing via webinar, telehealth, basically help the provider to take care of complex patients. Here, these are the few examples of acknowledgement we received. There were many, but just wanted to highlight, definitely the work ANMF did have boosted our morale at this time of crisis, just to name you the examples. We would not have been successful in this endeavor without help from all our partners, collaborators, and well-wishers, so we'd like to thank to them. So in conclusion, we think that above approach did have a significant positive and catalytic effect in important area of public health faced by the nation right now. I would like to thank you for your attention, and I would like that all of you will stay safe. Thank you.
Thank you very much. I think we're gonna have one extra talk from Ms. Satya Chaudhary. Please go ahead.
धन्यवाद डॉक्टर कोश, धन्यवाद। अब यसपछि काम गरिराख्नु भएको छ तपाईहरुको अर्गनाइजेसनले। यसपछि यो अनएक्सपेक्टेड एउटा नयाँ प्रेजेन्टेसन डाक्टर निशिता पाठकज्यूले गर्नुहुन्छ। उहाँको फर्स्ट सेसनमा थियो, तर टाइमको मिसअन्डरस्ट्यान्डिङले गर्दा उहाँको फर्स्ट सेसनमा छुटेको कारणले गर्दा म उहाँलाई टाइम दिन चाहन्छु। डाक्टर निशिता पाठक कन्सल्टेन्ट साइकियाट्रिस्ट हुनुहुन्छ सिभिल सर्भेन्ट हस्पिटल र अल्का हस्पिटलमा नेपालमा। उहाँ आर्म फोर्स हस्पिटलमा 15 वर्ष काम गरिसक्नु भएको छ। उहाँ युएसटीसी बङ्गलादेशबाट एमबीबीएस गर्नुभएको हो भने साइकियाट्रीमा IOM इन्स्टिट्युट अफ मेडिसिन त्रिभुवन युनिभर्सिटीबाट एमडी गर्नुभएको। डाक्टर निशिता, यू क्यान शेयर योर स्लाइड। डाक्टर निशिता सुनिराख्नु भएको छ? डाक्टर निशिता, तपाईको स्पिकर अफ छ।
Okay. Namaste. As I've been already introduced, I would like to go to my presentation. The topic of my presentation is mental health issues and migrant workers. As we all know that every year around 300,000 people migrants to other country for to work, and mostly to Malaysia, Gulf Cooperation Council, and India. And it comprises, the money they send back home comprises of 26.3% of total GDP of the country. Why do they migrate? Of course, in our country, we have limited employment, and then we have political instability, financial instability, poverty, and to earn a bulk of money in a very quick time. These are the common reasons that people usually migrate. And the many studies shows that there has been around 1,000 deaths per year, mostly due to the road traffic accident in the workplace, cardiac arrest, and other physical health problem and suicide. And then we receive a large number of people coming back home with a disability, physical health problem, and mental health problem. A study conducted by Padam Khara in 2017 shows that the most common cause of death was due to heart-related problem. And if you see in this slide, we see around 10.1% death was due to suicide. What the government is doing on migrants. Although Nepal has committed to migrant health work in the various national and international forums, including the World Health Assembly, it also includes some program and strategy that covers refugee and migrants, such as National HIV Strategy Plan in 2016 to 2021. But there is no legal framework, laws, regulation, and policies yet. It also says that all migration-related issues, including health of foreign migrant workers, should be covered by Ministry of Labor and Employment with its existing Foreign Employment Act and foreign employment policies. And the program it was supposed to cover is that there should be establishment of foreign employment welfare fund. There should be initiation of assisted voluntary return, referral mechanism to anyone with health issue, monitoring of pre-existing departure health assessment center of Nepal, and inclusion of health component in pre-departure orientation training package. But it seems it's only in the paper, it has never been implemented yet. A study conducted by Lee in 1960, he created push and pull theory about people migrations. Why do they migrate? Push theory, maybe there may not be enough job at home, few opportunity, living in the primitive conditions, natural disaster, some political fear or persecutions, and many other causes if you see in the slides. Whereas in the other part, the grass may be greener, there may be job opportunities, there may be a better living conditions, freedom for political and religion aspect, better education system. So these are few reasons where they migrate. Maybe it's within the country, from rural to urban area, or from one country to another for the better opportunities. Prevalence of mental health issue. According to WHO, 1 billion people have a mental health problem, and only more than 75 people living in low middle income countries has no access to mental health service. Whereas even in the high income countries, only 50% has an access to mental health service. And 1 in 5 may have a mental health problem during emergencies and disaster. If you see these slides here, this is a study conducted in China by Jian Li and published in International Health 2019, which shows that this was a study conducted in 3,286 participants from internal migrants from rural to urban, which shows that around 15.3 migrant workers had a higher prevalence of depression in comparison to non-migrant, and people of more than 45 years had a poor mental health conditions. Another article published, it is a health review, it's a journal review article published by Pratik Adhikari in Health Issue Among Nepalese Migrant Workers Working in the Middle East Asia, which shows that there are more risk of developing anxiety, depression, tuberculosis, eye injury. Besides that, other work-related accidents, there are high prevalence of suicide attempt and suicide. Likewise, another study published in 2014, Mental Health and Migration. This is a study done on a Kazakhstan population, which shows that almost half of the participants described their health as a fair or poor and reported no seeing a doctor, whereas 6.2% has a clinical depressions. There are many studies supporting that migrant health are at risk of developing depression, anxiety, and other kind of mental illness. The study conducted by Om Prakash Paudel, which shows the pre-departure psychological distress, depression, anxiety, and it was recently published, which shows that around 28.21% has a psychological distress, 41.3% has anxiety, around 35.9% has the depressions. This is one of the picture which was published in Kathmandu Post, where there were many feedback given by psychiatrists and psychologists how the migrant worker coming back home has developmental illness and which has been ignored from very before. Why do migrants are at risk of developing mental illness? Because these are the people who are who may face challenges like discrimination, gender inequality, sexual violence, and exploitations. Lives in work in a poor working environment and lives in the poor conditions, and there may be a difficult to access social and healthcare. Factors contributing to psychosocial problem, if you see according to social demographic profile, it is in more among female, young age, more among single, and in case of female separated or divorced, and the low level of educations. Before departure, it may be due to the less knowledge about the destination countries, maybe due to language, culture, the type of work they are going to work, and the skill of work. And the family pressures, loan going before abroad, presence of pre-existing mental illness in the family. And the most frequently reported symptoms, a study done on Ethiopian migrants who return home from Middle East shows that they around 40.6% had a frequent headache, 40 around had feel unhappy. Likewise, you see, sorry. Okay, we go to the around 17.1% had a suicidal thought. And the common mental health disorders are due to the low level of education. They may have experienced physical abuse, not getting salary in the proper time, mental illness in the family, and they may have experienced detentions or feeling guilty for not fulfilling the goal, and access to healthcare, which has been previously explained again. Back home, especially wife and parents experience social isolations. They worry excessively, live in the low mood. They may have fearfulness, disturbance of sleep, and anxiety, depression, and many other cases, and are at risk of developing violence by other people, in-laws. And just imagine receiving a grievous injury of the migrant workers or dead body, how it may contribute to psychosocial and mental health problems among the family. A focus group discussion done by PR Regmi and NR, this was the article published in Journal of Immigrants and Minor Health in 2020, which shows that families are as a source of poor mental health, unfair treatment at a workplace, poor arrangement of accommodation abroad, poor social life abroad, and loneliness and insecurity. So our literature review has suggested 4 key themes: risk factor related to Nepalese working in the foreign country, sexual health, work, lifestyle, patterns of migrant workers. Future directions, it needs more research, assessment of mental health, and more data should be required. It needs interventions, it needs awareness campaign, and needs of government to fulfill its mandate. My take-home message is mental health is equally important as physical health. Mental illness are common among migrant workers, which seems to be overlooked. 10% of death among migrants are due to suicide, which is preventable if timely access to mental health care is provided. Promoting mental health and its awareness, creating proper healthcare services, early identifications at pre-departure, during, and after may be helpful in increasing quality of life. Thank you.
Thank you. So we'll open the floor to the questions from any speakers to any speakers.
First of all, I would like to thank Dr. Nishita Pathak. That was a very, very good presentation. So actually, that's kind of an eye-opener. That was a great presentation. I have a question for the previous speaker, Nirmala Shrestha. That's kind of a general question. It's good that you brought out that, in your survey, there was quite a bit of mental health issues, more so in female compared to did we look into like a kind of mental illnesses? I know the later speaker pointed out that anxiety and depressions were 2 most common mental issues. But in your survey, did you look into how much was anxiety, how much was panic attack, insomnia, depression, and those kind of things? Because those are very commonly observed issues we have seen also.
Dr. Vishnu, कसलाई सोध्नु भएको question?
This question was for Nirmala, but I mean, I know your study talked about anxiety and depression. Did you also look into insomnia and panic attacks kind of things, Dr. Prasant?
Actually, we had, thank you. Thank you, Vishnu, sir, for the question. As we just told that we had just studied on the anxiety and depression using the hospital anxiety and depression scale, Nepali version, as well as the WHO disability assessment scale. So those two tools, basically, we only looked for the anxiety and depression because those were the most common one. Thank you. But you are right, like there are so many more to be looked upon.
Yeah, I think insomnia, I think needs to be looked into. I think insomnia is, I think, the major one, including the healthcare workers.
Exactly, yeah. And the another thing I would like to mention here is, I think we should also look after post intervention. You rightly told that along with this support with to Nepal Medical College, there was a webinar session for like giving the information on COVID to the many healthcare professionals. But I think now is the time to give the stress management packages, in form of webinars, in form of telephonic conversation, because I think many healthcare workers would need that in the background of the increasing COVID. But however, they are very far away from their family, and also being quarantined. And you might have like also followed that there are few doctors who, even after being positive, COVID positive, they are coming back to their hospital, because the new protocol says that after 2 weeks, even there is a positive test, that doesn't mean they get infected. So the healthcare are coming back, but there should be some kind of stress, relief packages for them. And I think maybe ANMF, NRNA, and of course our team is always ready for that. Thank you.
All right. I've got a question for Dr. Vishnu Sapkota. With ANMF work, I know that early on I was working with Dr. Santosh Sapkota, and through Ultimate Foundation, and then we were talking over, overnight and all this, to come up with all the fund and plans, and there's a lot of efforts goes into this, and you team have done excellent job, spending a lot of time and effort. My question is, how have you found a similar kind of enthusiasm and cooperation from government of Nepal or from that side? Have you, because I didn't find that I didn't find the government of Nepal very enthusiastic and cooperative when we try to work from our aspect, and because this is a big
Actually,
issue.
yeah.
Yeah,
Thank you
go
for the
ahead.
question. Thank you for the question, Dr. Kus. Actually, I know I kind of agree to some extent, but what we did was basically we tried to kind of go via Nepal Medical Council and Nepal Medical Associations, because we that way we thought probably it would be more productive. And definitely, when our task force initially worked with Nepal Medical Council and Nepal Medical Associations, they were actually able to come up with that initial guideline, which was actually endorsed by Ministry of Health later on. So there was a cooperation from Ministry of Health also, from the government side. But as you said, I think we found and I think everybody will find it's first easier to go through the like-minded organization, because they can facilitate our work better than the bureaucrats. But we did not get, I shouldn't say that we did not get support, but it's easier to go via like-minded other organizations who are there, and they can actually in turn will work with the government of Nepal. For us, the good thing is we have American Nepal Medical Foundations, the sister organization in Nepal also, who does all the required works with us together. That way, I would say we have been fortunate the way we have been able to work. Without that
Yeah,
organization,
yeah. That's what you got a strength, because you got
yeah,
NMF branch in
yes,
Nepal. You got
yeah,
all the senior doctors on your side, right?
yes. Otherwise, it would be
And,
impossible.
it would be impossible.
Exactly.
I was doing similar kind of work at a bit junior level, and it's not easy. And then it's very frustrating to see the lack of enthusiasm and support, especially in Ministry of Health, because we're in a high level committee, NRNA supported us, and we asked multiple times for the local level people to come to our meetings, but they never attended. There's a high level talk between our presidents and the prime ministers or foreign ministers, whatever, and they are very willing to take our the aid. They're very happy to take the aid, but to reciprocate in after that is not forthcoming. So I think from as the movement point of view, I think a health committee is doing great job, but I think we need to really push this issue that unless and until government of Nepal lends us open hand, there's no point for us to sweat day and night. But we still need to work for our Nepalese people, but the government needs to come on side as well. That's my view.
Yeah, I mean, I would not give up the hope, because I think we can work around, and eventually they will support us, and they have supported us also. They have recognized us. Like when we initially started this sample collection vehicle, we supported the sample collection vehicle, because remember that time there was kind of a chaos how to collect the sample, how to transfer the sample, and that portion ANMF supported, and Ministry of Health actually recognized it, and they actually recognize in their later saying that the American Nepal Medical Foundation will do it. So I think we should not give up the good job we want to do. We should continue to try, and I think it can be done. Eventually, we'll get the support. Everyone should support the good cause.
All right, let's move on, and then we talk to other speakers. Dr. Nishita, about the migrant health. I'm also quite interested in looking at the especially the suicide rate and also the workplace injuries. Is there much that can be done in that field to prevent those workplace injuries, and then also suicide rate of 10%?
Well, of course, the suicide is considered as one of the preventable death, and a lot can be done. Even like if you see how the people are going from Nepal to other countries to work, there are provisions where they go for a medical health checkup, but I would just recommend if someone add for psychological as well. But it seems that it is written there, and just an MBBS doctor rule out if the person is having any kind of problem or not. And due to the stigma attached and the discrimination attached with and lack of awareness among the people, they tend to hide the symptoms. And when they go to the destination country, the access to mental health care is very difficult. So providing any link with the country here back home, or providing telepsychiatry, telemedicine, I think that could be one of the service we can provide and take care of the people who are suffering. And running this kind of webinar, even running a 10 minutes video or 5 minutes video among the Nepalese community working in that place, about the awareness of mental health problem, how they can seek for help, and how to identify the problem on themselves, and how to cope up with the problem in a new place, how to the small thing can make a big differences, instead of these are the preventable. Even the COVID was there, we heard like many people committed suicide once the person was identified as a COVID, and he committed suicide into isolations. And because so many things happened when COVID was there, it was it was a big disaster before actually it was considered as a disaster. The fear was quite high. So many things can be done. And regarding insurance, of course, the policy should include the insurance of the person migrating from here to another work of other person. And if you see the people migrant, the only reason they go there is only to earn money. But there are so many things besides earning the money. The one thing they should consider about their safety. They should be well skilled or not, and the place they go, they should be, if they are aware or not, the problem they might face. So it should be included in the pre-orientation departure training, which is they have started, but this thing also should be involved, and the company should be responsible for creating the safe environment for the people who work for them. So this is my point.
The government has, you're telling me about the government has this welfare fund. So could you tell me a bit more about that and how that can be used to help these migrants? Thanks.
Well, sir, I don't think I am the right person to answer how this welfare fund is going to help these people. But all I can say that it secured the person, right? And then actually, if you see the sign, this government have agreed with the international labor organizations, everything they have. The government should initiate if someone wants to return home voluntary. They should provide access to healthcare if someone is having a problem in the destination country. So I would request anyone there, if you would like to answer these questions, how this welfare is going to help the people, then I'll be very happy.
No, I think
sorry to disturb, sir. 5 minutes बाँकी छ अर्को इभेन्ट सुरु हुनलाई, so I think we need to wrap up, sir.
Okay, I'll quickly ask one question to Dr. Manisha Sigdale about this pregnancy and COVID. Has that any top study been done in Nepal, and like that?
Not that I've seen. So this was the studies that we've seen. It's a more generalized data that we've collected in the US by CDC. But from my research, I haven't really seen a national collection of data within Nepal. And it's kind of hard to say because even here, just like I put a little bit of caveat into collecting data that is with the women who are affected by COVID, if they already have some type of respiratory or other type of comorbidities in the first place, and they contract COVID-19 on their death certificate, even the data that we collected, which is through the death certificates, it might not really include that it was because of COVID-19, even because they've had some type of underlying comorbidities in the past. So in Nepal, I wonder, even if we were to collect that type of data, if somebody already has, some type of illness already, would that be attributed to COVID-19 or not? So I don't know, just because of lack of being able to collect the data in Nepal in the first place, and then this other illnesses kind of interfering with COVID-19 on top of that, I think it might be a little bit of a challenge to collect that data.
Thank you.
धन्यवाद. हामी टाइम भन्दा 15 मिनट ढिलो भइसकेका छौं र हामीले ब्रेकको टाइम पनि युटिलाइज गरिसक्यौं. अबको 3 मिनट पछि नेक्स्ट सेसन सुरु हुन्छ र बीचमा हामीले ब्रेक लिदैनौं. यसपछिको सेसन हाम्रो प्रतीक छेत्रीज्यूले सञ्चालन गर्नुहुन्छ, डाक्टर सरोज निरोला र प्रतीक छेत्रीजी. अबको बीचमा आईटी का साथीहरु अबको बीचमा ब्रेक नलिदिनु होला. हामीसँग 2 मिनट टाइम छ. 2 मिनटमा दुईटा क्वेशन च्याटबाट आएको छ, त्यो दुईटा क्वेशन लिएर म त्यसपछि यो सेसन डाक्टर सरोज निरोला र प्रतीक छेत्री जी जो साइन्टिफिक लाई हस्तान्तरण गर्छु. हामीसँग 2 मिनट टाइम छ. 2 मिनटमा क्विक एउटा क्वेशन डाक्टर विष्णु सापकोटालाई छ. भन्नुहुन्छ, माय नेम इज किरण सापकोटा. ANMF has done wonderful work in Nepal. Does ANMF has any plan to help Nepalese elsewhere, such as in Middle East or India?
मैले त्यो एन्सर गरिसके, त्यो च्याटबाट एन्सर त दिइसके उहाँलाई. तैपनि अब हाम्रो बायोलजले चाहिँ नि हामीलाई नेपालमै फोकस गर्ने प्रेरणा दिन्छ. तर पनि द्याट्स अ फ्युचर डिस्कसन हैन, त्यसमा अब अहिले केही नभनौँ, तर I think that's a area to explore. तर हाम्रो बायोलज अनुसार चाहिँ नि our mission is to advance healthcare delivery in Nepal हो. तर पनि it's a matter of discussion भन्छु अहिले.
त्यसपछि लास्ट एक मिनट बाँकी छ यो Pranav Mehta. So was high CVD in Jain population surprising as their dietary habits were what we call healthy? Race plays more role. Does race play more role? As an
I'm not sure. Hello?
Yes.
Yeah, I'm not, could you clarify your question, please?
The question itself is not clear. I'm just reading. So, was high CVD in Jain population surprising as their dietary habits? Where what the question is so basically what does the race, like the Jain population, what does the race plays role in your study, like in cardiovascular disease?
Okay, so I guess I can answer the first part of that question, which was CBD, high CBD surprising with the diet? And so in our survey that we sent out, we assessed from different forms of diet: vegetarian, non-vegetarian, vegan, and complete Jain diet. And what we found was that most Jains are completely vegetarian, and those vegetarians were affiliated with the high CVD rates. And we don't think it's directly because of the vegetarian, but rather we think it's because of the high like carb diets, the high cholesterol diets, high salt diets that Jains have with many of the cultural cuisines that we have. So that's what we're assuming it is, and we're planning on doing further research to like narrow down that correlation.
Thank you. That was our last question. I would like to thank to all the presenters for presenting your wonderful research. Due to lack of time, we cannot take any more questions. And now I would like to hand over this session to Pratik Chhetriji. And all the presenters from session 2 can leave now. If they want to stay, they can stay, but it's the time for the presenters of session 3. So I would like to request all the presenters to you can leave the session. And I would like to hand over this podium to Pratik Chhetriji. Please go ahead.
Thank you. Thank you very much. I'm actually co-moderating the session with Dr. Sarita Nirola, who's also here. I'll quickly introduce myself. I am Pratik Chhetri. I work at the intersection of health, education, and leadership development, mostly in Nepal and India, and a little bit in California and US as well. Dr. Nirola, do you want to go?
Oh, yeah, sure. Thanks. So yeah, welcome everybody for this third scientific session. I think we have 6 speakers, so we should get going. Let me introduce myself briefly. So my name is Sarita Nirola. I'm a medical oncologist working with Cancer Care Manitoba, and I'm an associate professor of medicine at University of Manitoba in Canada. My clinical focus mainly is in treating solid tumors. I focus mainly in breast cancer. I am also a researcher, and my research focuses mainly on cancer policy, health services research, clinical trial methodology, and more recently in global oncology, which really is what brings me to this forum, if you wish. So I guess I'll stop there. We're here to learn more from our speakers so the first one, our first speaker will be Dr. Sarita Pandey Bhattara. Dr. Bhattara, or Pandey Bhattara, is an academic ENT and head and neck surgeon. She's working at Prairie Hospital in East London in South Africa. She's interested in head and neck oncology as well as in rhinology. She's been in South Africa from a very young age. She currently has 2 kids. She's a keen runner. And she's currently preparing for a full marathon. That's very impressive. I can't imagine myself doing that. Anyway, that's the way to go, Dr. Bhattara. So she's been involved in mRNA issues since 2015 earthquake, where she was part of the rescue effort. And it's with great pleasure that I welcome Dr. Pandey Bhattara to the forum. The floor is yours, Dr. Pandey Bhattara.
Thank you, Dr. Durrell, for a very gracious introduction. My study is basically a very short survey, so I'll just start with my slideshow. Let me just share my screen now. Okay, my survey basically looked into the availability and accessibility and utilization of healthcare services by the Nepalese across Africa. Now, I know that this is something I'm going to have to repeat every time I present this, because everyone sort of assumes that Africa is a small, a small place, but just not. It's the fifth largest mass of land in the world. It's got 5 different regions, which have 54 different countries and 5 different sovereign states. The population of Africa in general, total population, is 1.2 billion. So, and in terms of Nepali, sorry, I don't know what's happening here. Sorry. So in terms of Nepali population in Africa, we think there's only about 20,000 Nepali migrants, and they're all scattered throughout the Africa in general. But we think the majority of them are in 25 out of the 54 countries. We have been able to locate Nepalis in where the mRNA is active in about 16 of the countries. And the other Nepalis that we've just come to be in touch with now as we started the survey. The majority of Nepalis are in Mauritius. There's about 1,600 or 700 at the moment, and followed very closely by South Africa. We think there's about 1,000 of us here. In Africa in general, the majority of South African Nepali diaspora are illegal. They're brought here by the various agents with the promise to be taken from Cape Town to Johannesburg, from Johannesburg to New York, or to some American countries. And that's the story that all migrants actually tell us when we talk to them, when we get hold of them. But however, there is a historical part of it where a lot of Nepalis came here as a slave to sugar farms, together with the Indian counterparts. So because of the big landmass and because of the small amount of Nepalis that are here, the Nepalis themselves are very isolated within the African continent. So it is very difficult for us to actually locate them and sort of form a communication channel. So my aim of the study was to try to locate some of the Nepalis, from them if their healthcare in the country that they're residing in is accessible or not. If it was or not, to find out if we could do any interventional need for them at present. And once we found the need out, we planned to sort of aim to create a platform through which the Nepali people can sort of communicate with each other and with us as the medical professionals here in Africa and Nepal. So via the 4 factors that are written here. The method was a very simple survey. We designed it in such a way that it was designed to take minimum data and time. Data is very expensive in Africa, unfortunately. And it was shared via personal social media channels, as well as via various mRNA web pages across Africa. I started the survey. The survey only took 3 weeks to do it, and I stopped the responses on 10th of September this year. So due to the simplicity of the survey, I did the analysis by myself. And I decided at the end of the analysis to keep out some of the questions that were asked in the survey, because I felt that they sort of fell outside the aim of the survey. So we had only 62 respondents with more males than females, which was expected, as we know that the migrants in Africa are more males than females. Out of the 25 suspected cases of places countries that the African Southern Nepalis live in, we only had responses from 10 of the countries. So we think it's probably because of the time issue. We just didn't have enough time to sort of get the survey across to all 25 countries. As shown here, the majority of our respondents were young, between the age of 25 to 44 years. And this is in keeping with the general sort of my immigrant stats of young people leaving their country of origin to go into another country, which provides them with a sort of a better lifestyle, working, earning money. So coming to our focus of the study, do these people have accessible healthcare? A lot of them felt yes, they have accessible healthcare. About 23% of them said no, they don't have accessible healthcare. And we then decided to ask, what is your what type of healthcare do you have? Unlike the States, where Africa doesn't have universal healthcare, so to speak. We have our healthcare system is divided into private and public. Private is completely you pay for everything, or you can belong to one of those medical aids, medical schemes, and they pay for most of it. You just pay the short form of the treatment. Whereas the public is you pay minimal amount of fee to go into the hospital, and basically everything that needs to be done gets done for you. It obviously takes a lot of time. There's long waiting lists, all of that, but it gets done sooner than later than sooner. So we asked our respondents, who do you choose? And it's completely natural that they chose public, simply because our migrants here do not have proper health insurance that when they come here, so they cannot actually afford the private medical health care. We sort of broke that question down and asked them, which healthcare do you think is better? And everyone, the majority of them, 84% of them actually felt that the private healthcare was better. We do have some reasons that they've given. I'll elaborate on that now. And then we decided to ask them, has the healthcare that you've gotten so far been up to your expectations? And the majority of them said yes. There's a very close tie with the ones that said no. And I think this has got to do with the very few that went to the private sector and then those that went to public sector. But obviously we haven't really elaborated on this on the survey, so I cannot assume this. So the question I wanted to elaborate on is, why do you feel that one sector is better than the other? Now, a lot of people feel, and I think this is a true scenario, the private healthcare is a business, and it is absolutely true. Private healthcare is a business. Therefore, they're better equipped. They are better for good services. Once you pay, you get your services. You get what you pay for. But a couple of respondents from our Northern African countries said that private hospitals do not have specialists, and that's also very true. Africa has a severe lack of specialists in various fields, and ENT is one of them, actually. We have a lot of doctors that come to South Africa to train as ENT specialists, and they go back to their country once the training is done. But they really do not have specialists in Northern Africa, quite a few. Now, the public, against the public system was a long waiting list, and that it was crowded, and it was understaffed, and it was not properly managed, and treatment was not good. For some reason, our Nepali migrants, and in general, Nepali people, I suppose, feel that in public hospitals, treatment is not that great because they get the generic drugs. They don't get trade names. They don't get, what they think is a good version of the drug. There were some general thoughts about the survey as well. Some said healthcare in Africa is careless. I'm not 100% sure what they meant by that statement, but then they went on to sort of quantify that statement by saying it's not better than any other countries, which I think I would have to find the respondent to try to get some elaboration there. What is true is that COVID-19 has resulted in hospitals being full and there's no healthcare available for general public. It is true that COVID-19 has actually stopped all of non-emergent hospital visits. We're only seeing emergency patients at the moment. We were only seeing emergency patients at the moment, and all the elective operations, everything had been postponed. My personal tonsillectomy list that was waiting list had a waiting list of about 2 months is now about 6 months. So patients have to wait for 6 months to get a tonsillectomy in public sector. And yes, resource allocation in private is better simply because the private is a business. And a lot of Nepalis also feel that there's more corruption in public hospital. I'm not 100% sure about that statement either, but I had thought that is something that sort of resonates with everybody that's about public healthcare in general. So based on this pilot study, it's a very short, small study, we conclude that Africa at present, the Nepali diaspora have adequate and accessible healthcare. However, I feel the expectations of healthcare might be higher than what they're actually receiving. And I think this survey sort of points towards the ideation that further studies are required before planning and implementing any interventions of any sort. And this survey actually points out there's a gap in the actual locations of the migrants across Africa, and we need to sort of map these patterns before we decide what is urgent, what is not urgent. The limitations and strength of the study, I mean, the limitations is also its own strength. It is a simple survey. And I only had 3 weeks from consumption to completion of the study, so we did not reach everybody else. Maybe if we had reached the 4,000 people, we might have had a different sort of a picture to it. And yeah, the sample was also very small due to time. And there's a lot of bias in the study from our respondents as well, because they they sort of, everything is biased towards the private healthcare, I feel, from the answers that we got. And I think the strength of the study is also the simplicity of the study, in the sense that it was very easy to fill, and it took only about 2 to 3 minutes for them to just click and choose the answer of their choice. And it didn't take too much of a data, so those that got it actually filled it in and said thank you for this, because it didn't take too much data as well. However, and this study itself, we were able to recognize some common illnesses, which I did not put on the study, because I feel we need to actually do more research on that before I actually tabulate it. And I think we'll be able to create a sort of an educational website or a social media page discussing these issues. That's all. Thank you so much.
Thank you. Thank you. I guess because of heterogeneous nature of the topics that we have in this session, I would suggest that we take questions as we go on. So I don't know if there is any questions in the chat room. I don't see any. I guess I think that's a really fabulous research work, Dr. Bhattara. It's really suitable for the forum that we're speaking at. And thank you for your hard work. So you obviously need not look at this issue, but how do you think your results compare to your local South African population? I guess what I'm trying to get at is to ask to expand a little about the disparity between immigrants and the locals in South Africa. Just to give us a small snapshot of your opinion on what's going on.
Okay, so the South Africa's locals, and I'm talking about the general population, the locals. They're all basically living in almost at a poverty level, just like slightly above poverty level. And as I don't know if you have heard that our economic status has now been turned to even be going lower because of all the corruption and the various other factors deciding our economy. So yes, our population in general is very not well off, and which is why our public health care system is so busy and so overrun with everything. It's like we're a backlog of everything. And in comparison, the Nepali migrants that come here, they tend to expect almost a private care. I've actually spoken to a few of these guys here, and they tend to sort of would rather save a couple of months worth of salary and go to one doctor to see, for a rash that they could have gone to a local clinic and gotten a treatment for free. Whereas the public here is very patient in terms of they know that I think they sort of have agreed that this is a long process, and we don't really get that much of a anxiety and that much anger from the local patients as we get from our Nepali migrants that want us to treat them. And as you know, it's as a doctor, it's impossible to when someone phones you and says, "Oh, my son has an issue with his ear. What can I do?" I mean, maybe in Nepal, I could say, go to this shop and buy the XYZ and treat it and then see what happens. Whereas here, we can't do that. We've got to actually see the patient. I mean, there are laws, we have to see the patient, if we treat the patient, diagnose the patient, and then, treat the patient. Yeah, I think the economic structures of our migrants are slightly better than our local population. Yeah.
Yeah, no, great, thanks. I think we have a couple of comments in the question answer. Samita Pandey writes that in Alberta, Canada, where I am, South African trained physicians are extremely sought after. So that's great, and not surprising, of course. Approximately 75% of rural physicians are from South Africa. Oh, I didn't know that.
Yes, they are. Yes, yeah.
Wow, that's fabulous. So that's
it's fabulous
good.
for Canada, but it's really bad for us.
I know. I'm in Canada. I have to be a little bit selfish over here. Anyway, that was a joke. So I think in the interest of time, we should move on. Our second speaker is Dr. Dinesh Durrell. Dr. Durrell was trained as a pediatrician from Institute of Medicine, Coven University in Nepal, of course, and was further trained in neonatal perinatal medicine from University of Calgary in Canada. He has been a pediatric faculty in Nepal over 3 years before he came to Canada, and is currently working as a clinical associate in neonatal intensive care unit at Jim Pattison Children's Hospital in Saskatoon, Canada. Dr. Durrell is also pursuing a master's degree in community health and epidemiology at University of Saskatchewan with an interest in global maternal and newborn health. His research have focused on newborn health issues, particularly breastfeeding. Dr. Durrell volunteers with America Nepal Medical Foundation through their Research, Education and Development Committee and Research Development Committee and Coordination Committee. So with great pleasure, I now welcome Dr. Durrell. Please take the forum, Dr. Durrell.
Thank you. I'm trying to share my PowerPoint and can I? मेरो स्क्रिनले नै कस्तो अहिले अर्कै प्लेटफर्मबाट खुले जस्तो छ.
I think you have to click the arrow just beside stop video. Oh no, I don't think that's the one. Share screen. Yeah, there's a green thing down there. Do you see that?
Yes.
Excellent. I think yes.
हजुर.
But we can see your desktop background.
हजुर मैले त्यो खुलिरहेको.
Okay.
Sorry about this.
No problem.
Okay. Slideshow. Okay. Namaste. शुभ प्रभात, शुभ दिन, शुभ सन्ध्या, शुभ रात्रि जो जहाँ हुनुहुन्छ. मैले अहिले प्रेजेन्टेसन गर्न लागेको टाइटल छ हायर रेट्स अफ अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङ एसोसिएटेड विथ हेल्थ फेसिलिटी डेलिभरी इन नेपाल. यो चाहिँ नेपालको डेमोग्राफिक हेल्थ सर्वेको डेटाबाट एनालाइसिस गरिएको रिजल्ट हो र यसमा मलाई सहयोग गर्नुहुने साथीहरू पवन, अस्मिता, युवराज र किरण प्रति म आभार व्यक्त गर्न चाहन्छु. अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङ भनेको चाहिँ बच्चा जन्मेको 1 घण्टा भित्रमा स्तनपान सुरु गर्नु हो, जुन चाहिँ वर्ल्ड हेल्थ अर्गनाइजेसनको रिकमेन्डेसनमा पर्छ र कोलोस्ट्रम फिडिङ ब्रेस्ट फिडिङको एडभान्टेज जस्तो न्युट्रिसनल बेनिफिट, यसले रोगबाट लड्न सक्ने क्षमता विकास गर्ने बेनिफिट र ओभरअलमा नवजात शिशुको मृत्यु दर घटाउने बेनिफिटको बारेमा त विभिन्न स्टडीहरूले देखाएको छ. यो नेपालको म्याटर्नल हेल्थ प्रोग्रामहरू, न्युबर्न हेल्थ प्रोग्रामहरूले हेल्थ फेसिलिटी डेलिभरीलाई प्रोत्साहन गर्ने गरेको छ. जस्तो 1997 मा सेफ मदरहुड प्रोग्राम सुरु भएदेखि र विशेष गरी यो 2005 to 2009 को बीचतिरमा जुन हेल्थ फेसिलिटी डेलिभरीलाई इन्सेन्टिभाइज फाइनान्शियली इन्सेन्टिभाइज गर्ने प्रोग्रामहरू सुरु भयो. 2007 मा कम्युनिटी बेस्ड न्युबर्न केयर प्रोग्राम र जस्तै अरू न्युबर्नलाई फोकस गरिएका प्रोग्रामहरू सुरु भएर ती चलिरहेका छन् र यिनीहरूले चाहिँ यो अत्यावश्यक शिशु स्याहार एसेन्सियल न्युबर्न केयरको मेसेजहरूलाई चाहिँ प्रोत्साहन गर्ने गरेको छ. यही सन्दर्भमा चाहिँ यो गएको 2 दशकभित्र अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङ को ट्रेन्ड कस्तो छ र यसमा हेल्थ फेसिलिटीमा डेलिभरी यो स्वास्थ्य संस्थामा प्रसुति गराउँदाको बेनिफिट यसको सम्बन्ध के कस्तो छ भन्ने बारेमा चाहिँ हामीले एनालाइसिस गरेका हौं. हाम्रो डाटा सोर्स भनेको नेपाल डेमोग्राफिक एन्ड हेल्थ सर्वेको लास्ट 4वटा सर्वे डेटा हुन् जुन 2001, 2006, 2011 र 2016 मा गरिएका थिए र हाम्रो आउटकम भेरिएबल सर्वे गरिएको टाइम को 24 महिनाभित्र जन्मेका शिशुहरूको आमालाई सोधिएको प्रश्नको आधारमा कति शिशुहरूलाई चाहिँ 1 घण्टाभित्रमै स्तनपान गरियो भन्ने कुरा चाहिँ हाम्रो आउटकम भेरिएबल हो भने हाम्रो मुख्य एक्सपोजर भेरिएबल प्लेस अफ डेलिभरी स्वास्थ्य संस्थामा जन्मियो अथवा घरमा जन्मियो भन्ने हो। हामीले अरू कोभ्यारिएटहरू पनि हेरेका थियौँ, सोसियो डेमोग्राफिक, म्याटर्नल र इन्फान्ट क्यारेक्टरिस्टिक्सहरू र एनालाइसिस गर्दाखेरि सर्वे इयरले हामीले हेर्न खोजेको एसोसिएसन प्लेस अफ डेलिभरीको यो अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङसँगको रिलेसनसिपलाई चाहिँ मोडिफाई गरेको देख्यौँ। त्यसैले हामीले पुरै पुलमा नगरेर 2वटा पुल 2001 र 2006 लाई अर्लियर कोहोर्ट र 2011 र 2016 को DHS ले क्याप्चर गरेको लेटर डिकेडको अर्को छुट्टै कोहोर्टमा चाहिँ मल्टिपल लजिस्टिक रिग्रेसन गरेर डिटर्मिनेन्ट्सहरू हेर्यौं र रिजल्टमा चाहिँ ओभरअल पुलमा अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङको रेट चाहिँ 40% छ जुन ग्लोबल नम्बरसँग कम्पेरेबल छ। 2016 मा अराउन्ड 50% को चाहिँ अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङ थियो र हाम्रो यो 2016 को NDHS ले पनि यो 54% देखाएको छ। र यसमा हेल्थ फेसिलिटीमा जन्मेका बच्चाहरू स्वास्थ्य संस्थामा जन्मेको शिशुहरूमा चाहिँ यो रेट बढी छ। ओभरअल पुलमा 53% कम्पेयर टु होम डेलिभरीमा 34%। हामीले यो 2001 देखि 2016 सम्म हेर्यौं भने यी सबै दरहरू क्रमिक रूपमा बढिरहेको पाउँछौं। जस्तो 2001 मा हेल्थ फेसिलिटी डेलिभरीमा 33% बाट 2016 मा 59%, 26% ले बढेको भेटिन्छ भने होम डेलिभरीको केसमा चाहिँ 2001 मा 30% बाट 2016 मा 47% बढेको भेटिन्छ। र डिटर्मिनेन्ट्सहरू हेर्दाखेरि चाहिँ यो हाम्रो मेन भेरिएबल एक्सपोजर भेरिएबल हेल्थ फेसिलिटी डेलिभरीमा यो पछिल्लो डिकेडमा 2011-2016 को डिकेडमा हेर्दाखेरि अड्स रेसियो 2.3 भन्नाले 2.3 टाइम्स चाहिँ हेल्थ फेसिलिटीमा जन्मेको शिशुले 1 घण्टाभित्रमै स्तनपान गर्ने सम्भावना हुने रहेछ कम्पेयर टु होम डेलिभरी। तर यो रिलेसनशिप चाहिँ अरु भेरिएबलहरुसँग एडजस्ट गर्दाखेरि यो 2001 to 2006 को डिकेडमा चाहिँ सिग्निफिकेन्ट एसोसिएसन देखिएन, जबकि यो एडजस्ट गर्नुभन्दा अगाडि चाहिँ सिग्निफिकेन्ट नै थियो। हामीले एडजस्ट गरेको कोभ्यारिएटहरु चाहिँ मदर्स एजुकेसन, मदर्स अकुपेसन, फादर्स एजुकेसन, रेजिडेन्स बाइ अर्बन रुरल, इकोलोजिकल रिजन, प्रोभिन्स, इथनिसिटी, वेल्थ क्विन्टाइल, मदर्स एज, चाइल्ड सेक्स, बर्थ अर्डर, मल्टिपल बर्थ, साइज एट बर्थ, एन्टिनेटल भिजिट, प्लेस अफ डेलिभरी, मोड अफ डेलिभरी र मिडिया एक्सपोजर हो। हामीले यो हाम्रो प्राइमरी एक्सपोजर भेरिएबल हेल्थ फेसिलिटी डेलिभरी बाहेक यो नर्मल डेलिभरीको कम्प्यारिजनमा सिजरियन सेक्सनबाट जन्मेको शिशुहरूमा चाहिँ अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङको रेट चाहिँ सिग्निफिकेन्टली कम पाइयो। यो दुवै कोहोर्टमा अघिल्लो दशक र त्योभन्दा अगाडिको यो पछिल्लो दशकमा पनि। तर मदर्स एजुकेसनसँग चाहिँ पोजिटिभ एसोसिएसन थियो। जस्तो एजुकेटेड मदर्सको प्राइमरी और सेकेन्डरी र हायर एजुकेसनमा चाहिँ यो रेट चाहिँ अनएजुकेटेड मदर्सको तुलनामा बढी पाइयो दुवै कोहोर्टमा। र अरु फ्याक्टरहरू जस्तो रुरल अर्बन रेजिडेन्स, वेल्थ क्विन्टाइल, एन्टिनेटल भिजिट, बर्थ अर्डर, साइज एट बर्थको पनि सिग्निफिकेन्ट एसोसिएसन वान अर द अदर पुलमा भेटिएको थियो। अब समग्रमा भन्नु पर्दा गएको 2 दशक भित्रमा अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङ चाहिँ यो बढ्दो क्रममा नै भेटिन्छ र हेल्थ फेसिलिटी डेलिभरीसँगको एसोसिएसन चाहिँ यो पछिल्लो दशकमा सिग्निफिकेन्ट एसोसिएसन भेटिन्छ यो अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङसँग। तर यो एसोसिएसन चाहिँ अघिल्लो दशकमा चाहिँ सिग्निफिकेन्ट भेटिएन। यो किन होला भनेर हेर्दाखेरि चाहिँ यो पछिल्लो दशकमा हेल्थ फेसिलिटी डेलिभरीलाई प्रोत्साहन गर्नको लागि प्रोग्रामले फोकस गरेको छ। सँगसँगै इसेन्सियल न्युबर्न केयरको मेसेज, त्यसको 5 वटा की मेसेज मध्ये एउटा चाहिँ बच्चा जन्मेको 1 घण्टाभित्रमै स्तनपान सुरु गराउने भन्ने छ। त्यो इसेन्सियल न्युबर्न केयर चाहिँ हेल्थ फेसिलिटीमा जन्मे पनि त्यो कुरालाई चाहिँ अझ बढी प्रोत्साहन प्रोग्रामले नै अलि बढी फोकस गर्न थालेको देखिन्छ। मलाई लाग्छ हामीले भेटेको यो पोजिटिभ रिजल्ट भनेको चाहिँ यही प्रयासको रिजल्ट हुन सक्छ। यसमा अरू फ्याक्टरहरू पनि हुन सक्छ, तर अब्भियसली देखिने एउटा फ्याक्टर भनेको चाहिँ यो हो। र अहिले हामीले यो अर्ली ब्रेस्ट फिडिङको अर्ली इनिसिएसनको लागि 1 घण्टाभित्रमै सुरु गराउनको लागि फोकस गर्नुपर्ने अर्को एउटा इम्पोर्टेन्ट ग्रुप भनेको चाहिँ सिजेरियन सेक्सनबाट जन्मेको बच्चाहरू, जसमा चाहिँ 1 घण्टाभित्रमै स्तनपान गराउन सम्भव छ तर अलिक गाह्रो छ। यो ग्रुपमा फोकस गर्नुपर्ने देखिन्छ। साथै अनएजुकेटेड मदर्सबाट जन्मेको बच्चाहरूमा पनि यो अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङको एडभान्टेज दिनको लागि चाहिँ यो इक्विटीको सवाल हो। यसको लागि चाहिँ प्रोग्रामले अलिक बढी जोड दिनुपर्ने देखिन्छ। र अहिले कोभिड पेन्डेमिकको बेलामा हेल्थ फेसिलिटीमा डेलिभरी गराउने कुरामा पनि कतै घट्ने पो हो कि भन्ने डर देखिरहेछ। अब डेटाहरूले के देखाउँछ हेर्न बाँकी नै छ। र ब्रेस्ट फिडिङ 1 घण्टाभित्रमै सुरुवात गराउन र ब्रेस्ट फिडिङ प्रमोट गर्नको लागि यो कुरा चाहिँ अझ बढी सान्दर्भिक देखिन्छ। अहिले म मेरो प्रेजेन्टेसन यही अन्त्य गर्न चाहन्छु। यहाँहरूको यदि कुनै प्रश्न, जिज्ञासा र सुझावहरू छ भने मलाई सोध्न सक्नुहुन्छ, अथवा अहिले सक्नु भएन भने यो मेरो इमेल एड्रेसमा इमेल गर्न सक्नुहुन्छ। थ्याङ्क यू।
धन्यवाद डाक्टर दिनेश दरेलज्यू। यहाँको अत्यन्त सान्दर्भिक र महत्त्वपूर्ण शोध प्रस्तुत गर्नुभएकोमा यहाँलाई म सादर धन्यवाद ज्ञापन गर्न चाहन्छु। यहाँलाई मेरो 2 वटा प्रश्न छन्। पहिलो प्रश्न, यहाँको विचारमा अहिले भइरहेको कोभिड महामारीको समयमा यसको यहाँको शोधको सान्दर्भिकताको बारेमा अलिकति प्रकाश पारिदिनु हुन अनुरोध गर्दछु। र साथै दोस्रो प्रश्न के भने, यहाँले जुन डेटाहरू देखाउनु भएको थियो यसमा यो स्वास्थ्य संस्था बाहिर जन्मिएका बच्चाहरूको जुन अङ्कहरू यहाँले लिनुभएको छ त्यसको विश्वसनीयताको बारेमा पनि प्रकाश पारिदिनु हुन म नम्र अनुरोध गर्दछु। धन्यवाद।
हजुर, थ्याङ्क यू। एकदम महत्त्वपूर्ण सवाल उठाउनु भयो। यो फेसिलिटी डेलिभरी स्वास्थ्य संस्थामा प्रसुति गराउनुको एडभान्टेज त हाम्रो यो नेपालको डेटाले पनि देखाएको छ, समग्र विश्वको डेटाले नै देखाएको छ। हेल्थ फेसिलिटीमा बच्चा जन्माउनु घरमा जन्माउनु भन्दा सुरक्षित हुन्छ र यसले न्युनेटल आउटकम बच्चाको सर्भाइभलमा धेरै प्रभाव पार्छ भन्ने कुरा त महत्त्वपूर्ण छँदैछ। अहिले कोभिडको कारणले कति मान्छेमा यो हेजिटेसन छ, स्वास्थ्य संस्थामा जाँदाखेरि झन् कोभिड नै लाग्ने हो कि भन्ने। तर यो थ्योरिटिकल मात्रै पनि हुनसक्छ, सायद नघटेको हुनसक्छ। तर कति रिपोर्टहरू, कति ठाउँको यो रिपोर्टहरू हेर्दाखेरि चाहिँ कतै यो महत्त्वपूर्ण हेल्थ इन्टरभेन्सनलाई चाहिँ असर गरेको हो कि भन्ने अवस्थामा यो जुन हेल्थ फेसिलिटी डेलिभरीको एडभान्टेज मध्ये एउटा चाहिँ अर्ली इनिसिएसन अफ ब्रेस्ट फिडिङ पनि हो भन्ने कुरालाई अगाडि ल्याउँदाखेरि चाहिँ एउटा न्युबर्न सर्भाइभलको डाइरेक्ट इफेक्ट र ब्रेस्ट फिडिङबाट हुने आमाको दुधबाट हुने बेनिफिटले गर्दाखेरि हुने एडिसनल बेनिफिटलाई पनि जोडेर हेर्दाखेरि चाहिँ स्वास्थ्य संस्थामा बच्चा जन्माउनु जरुरी छ, महत्त्वपूर्ण छ भन्ने कुराले यसलाई हाइलाइट गरेको छ। अर्को कुरा चाहिँ जस्तो कोभिड इन्फेक्सन हुँदाखेरि यो बच्चालाई पनि सर्ने हो कि स्तनपान गराउनु हुन्छ कि हुँदैन भन्ने कति खालको जिज्ञासा पनि हुनसक्छ, कतिमा हुँदैन कि भन्ने भ्रम पनि हुनसक्छ। तर ब्रेस्ट फिडिङ गराउन नै रिकमेन्ड गरिएको छ। म एउटा अलिकति मेरो यो प्रेजेन्टेसनभन्दा अलिकति बाहिर गएर तर अहिलेको लागि सान्दर्भिक हुने एउटा इन्फर्मेसन एड गर्न चाहन्छु। यदि बच्चालाई सुरक्षित तरिकाले दुध निचरेर दियो भने बच्चाले त्यो आमाको दुधको बेनिफिट पाउन सक्छ। यदि आमालाई पोजिटिभ नै छ भने पनि, जस्तो सफाइहरूमा ध्यान दिने, बच्चालाई डाइरेक्ट मास्क लगाउने, डाइरेक्ट कन्ट्याक्टमा आउन नदिने लगायतका विभिन्न कुराहरू प्रयोग गर्दाखेरि भनेपछि यो कोभिड इन्फेक्सनकै बेलामा पनि ब्रेस्ट फिडिङको एकदमै महत्त्वपूर्ण रोल छ। त्यही कारणले यो बेलामा पनि यसलाई चाहिँ जारी राख्नुपर्छ, यो बेला अझ बढी महत्त्वपूर्ण होला भन्ने कुरा यसले देखाउँछ। र अर्को डेटाको रिलायबिलिटीको कुरा चाहिँ यो पुरै डेटा हेल्थ फेसिलिटीमा जन्मेको होस् अथवा घरमा जन्मेको होस्, यो डेटाको स्रोत भनेको चाहिँ इन्टरभ्यू हो, सर्वे। यो नेपाल डेमोग्राफिक हेल्थ सर्वे जुन चाहिँ एकदम सिस्टमेटिक तरिकाले डिजाइन गरिएको सर्वे क्वेसनहरू, यो चाहिँ जस्तो नेपालमा अहिलेसम्म 5वटा भइसक्यो, अरू देशहरूमा संसारभरि नै विभिन्न देशहरूमा भइरहेको छ। यसको स्ट्यान्डर्ड सर्वे मेथडबाट आमाले दिएको जवाफको आधारमा हो। त्यसैले आमाले बच्चा घरमा जन्मेको अथवा हेल्थ फेसिलिटीमा जन्मेको भनेर जे भन्नुहुन्छ त्यही एन्सर रेकर्ड गरे हुन्छ। ब्रेस्ट फिडिङको तुलनामा के अरे सन्दर्भमा पनि त्यही नै हो। त्यही कारणले यो इन्टरभ्यूबाट लिएको डेटा भएको कारणले एज लङ एज इन्टरभ्यू इज कन्डक्टेड इन रिकमेन्डेड वे, यो चाहिँ डेटालाई रिलायबल मान्नुपर्छ। थ्याङ्क यू।
हस्, धन्यवाद डाक्टर दुर्रेल। यो मातृ शिशु स्वास्थ्य जस्तो अत्यन्त संवेदनशील विषयमा यहाँले प्रकाश पार्नुभयो र आफ्नो शोध पत्र प्रस्तुत गर्नुभयो, यसको लागि विशेष धन्यवाद। Now I think we have to move on. We're kind of short of time. So our third presenter today will be Dr. Ramsey Gimeri. He is General Secretary of Association of Nepali Agricultural Professionals of Americas, also named NAPA, N-A-P-A. Dr. Gimeri has previously served for over 16 years at the Department of Livestock Services within Nepal's Ministry of Agriculture. Dr. Gimeri earned his PhD in Community Agriculture, Recreation and Resource Studies at the Michigan State University in the United States, following his prior trainings in India and Australia. He's involved in multiple research activities in evaluation training program and coordinates the Michigan State University International Food Safety Training course. And he is well published in that area. So it gives me a great pleasure to welcome Dr. Ramsey Gimeri to the forum. Dr. Gimeri, please.
Thank you, Dr. Durrell, for a nice intro. Can you see my slides? All right.
Yeah, we can see it. Yes, go ahead.
All right. मेरो presentation as a role of associations of Nepalese agricultural professionals of Americas in Nepal's food security during coronavirus pandemic and beyond यो विषयमा छ। अघि डाक्टर निरौलाले भने जस्तै हामी नापाका विभिन्न साथीहरू म लगायत डाक्टर सन्तोष ढकाल, हाम्रो प्रेसिडेन्ट डाक्टर मेघ पराजुली, अर्को भाइस प्रेसिडेन्ट प्रदीप वाग्ले र हाम्रो एक्स प्रेसिडेन्ट लीला बहादुर कार्कीले यो तयार गर्नुभएको। म आई वुड लाइक टु थ्याङ्क देम अल फर कन्ट्रिब्युटिङ टु प्रिपेयर दिस पेपर। जब नेपालमा कोरोना भाइरसको लागि लकडाउन सुरु भयो मार्च 24बाट, त्यसपछि सबै सेक्टर प्रभावित भए। ह्युमन हेल्थ त भइहाल्यो र त्यो सँगसँगै एग्रिकल्चर सेक्टर चाहिँ र यसको भ्यालु चेन चाहिँ इक्वल्ली सिभियरली अफेक्टेड भयो। आई मिन भ्यालु चेन मिन्स यो प्रोडक्सनदेखि अन्तिम कन्ज्युम्सनसम्म, यो बिचमा आउने हार्भेस्टिङको कुराहरू, कलेक्सनको कुराहरू, स्टोरेजको कुरा, प्रोसेसिङको कुरा, डिस्ट्रिब्युसन ट्रान्सपोर्टेसनको कुरा र मार्केटिङको कुरा र अल्टिमेट कन्ज्युम्सनको कुरा, एभ्रिथिङ गट अफेक्टेड। र फर इक्जाम्पल यहाँले थाहा पाउनु भएको छ यो नेपालमा अहिले पनि यो क्राइसिस भइरहेछ। केमिकल फर्टिलाइजरको धानमा किसानले चाहिँ केमिकल फर्टिलाइजर नपाएको स्थिति छ, ह्याभोक भइरहेछ। त्यस्ता अनेकौँ घटनाहरू छन् जसले गर्दा कृषि उत्पादनको गर्नको लागि चाहिने इनपुटहरू चाहिँ किसानले नपाएर कृषिलाई असर गरेको छ। र यसले गर्दा मैले अघि नै भने यसबाट फुड प्रोसेसिङ, डिस्ट्रिब्युसन्स, फुड प्रोडक्सन, एभ्रिथिङ इज अफेक्टेड। र यो पनि यहाँले हामीले देख्यौँ कि केही महिना अगाडि, केही हप्ता अगाडि जुन त्यति मात्रै होइन, यो चेनमा यसले मात्रै अफेक्सन होइन कि एक किसिमको मिसइन्फर्मेसन पनि फ्लो भयो। जहाँ फ्रुट र भेजिटेबलको कन्ज्युम्सनबाट अथवा फ्रुट र भेजिटेबल एउटा जहाँ इन्फेक्टेड एरिया छ त्यहाँबाट अर्को इन्फेक्सन नभएको ठाउँमा लग्दाखेरि यसबाट कोरोना सर्छ त्यस्तो फ्रुट भेजिटेबलबाट भनेर त्यस्तो मिसइन्फर्मेसन पनि भयो। त्यसले गर्दा उत्पादन भएर कन्ज्युम्सनको लागि रेडी भएको फ्रुट भेजिटेबल पनि कन्ज्युम्सन उपभोक्ताले नपाउने स्थिति आयो। यी सबैले गर्दा के भयो भने एकातिर फुड प्राइसेसहरू बढ्दै गयो, अर्को कुरा एभाइलेबिलिटी र एक्सेसिबिलिटी घट्दै गयो र अन टप अफ द्याट हामीले गरेको एउटा सर्वेले के देखाउँछ भने रेमिट्यान्स पनि घट्दै गयो, जसले गर्दा अधिकांश रेमिट्यान्समा आश्रित मान्छेहरूको चाहिँ पर्चेसिङ पावर पनि घट्दै गयो। यी सबैले गर्दा विशेष त डेली वेज लेबरर, सेल्फ इम्प्लोइड इम्प्लोइज अर्थात् एन्टरप्रेनर, migrant worker, elderly people, women, they got most affected. र यी सबैको अल्टिमेट के भने ह्युमन हेल्थमा परिरहेको छ। हामीले देखिरहेको छौँ घटनाहरू, अघिका प्रेजेन्टेसनहरूमा पनि आयो विभिन्न किसिमको स्ट्रेसको कुराहरू, अर्थात् योभन्दा अगाडिका सेसनमा भएको प्रेजेन्टेसनहरूमा पनि डिप्रेसनको कुराहरू, सुसाइडका केसहरू विभिन्न आइरहेछन् र न्युट्रिसनल डिफिसियन्सी र त्यसबाट हुने किसिमका अरू कम्प्लिकेसन त छँदैछन्। अब यो स्थितिमा अब विभिन्न पब्लिक, प्राइभेट र नन प्रफिट अर्गनाइजेसनहरूले के गर्न सक्छन् त भन्ने कुरा आउन सक्छ। यो मध्येको हाम्रो एउटा अर्गनाइजेसन चाहिँ नापा हो। नापा मैले अघि पनि भने यो चाहिँ नेप्लिज एसोसिएसन्स अफ एग्रिकल्चर प्रोफेसनल्स अफ अमेरिका यसलाई फुल फर्म भनिन्छ। यसमा ओभर 400 मेम्बर्सहरू आबद्ध छन्, जुन चाहिँ अमेरिकाज, अस्ट्रेलिया, युरोप, नेपाल, अमेरिकाज मेन क्यानाडा एज वेल रिप्रेजेन्ट गर्छन् र युएसको ओभर 41 स्टेटबाट यसका मेम्बरहरू छौँ। हामी विशेषतः युनिभर्सिटीको फ्याकल्टीहरू, रिसर्चरहरू, गभर्मेन्ट इम्प्लोइजहरू युएस र नेपालको छौँ। र नापाजको अप्रोच यस्तो कोभिडको महामारी हुँदा र अब हुने किसिमको डिजास्टरहरूमा के गर्ने त भन्दा वी बिलिभ द्याट एजुकेसन, रिसर्च एन्ड एक्सटेन्सन सुड गो टुगेदर र सबैको फोकस चाहिँ एन्ड युजर र अरू स्टेक होल्डरलाई पनि सँगै साथ लाग्दै काम गर्नुपर्छ र एक्सटेन्सनलाई रिसर्चले ब्याकअप गर्नुपर्छ, एजुकेसनलाई रिसर्चले ब्याकअप गर्नुपर्छ। तब मात्र हाम्रो जुन हामीले एफोर्ट लगाउँछौँ त्यो चाहिँ दिगो हुन्छ भन्ने हाम्रो सोचाइ छ। र नापाको लाई अहिले एक्जिक्युटिभ कमिटीलाई सपोर्ट गर्नलाई वी हेभ 12 सब कमिटिज द्याट इन्क्लुड्स एडभाइजरी काउन्सिल, रिसोर्स क्यापासिटी बिल्डिङ कमिटिज, एग्री कनेक्सन एडिटोरियल बोर्ड, मोर यु क्यान सी हियर इन द स्लाइड्स द्याट केहीको चाहिँ म अलिकति इलाबोरेट पछि पनि गर्नेछु। नापाका मेजर एक्टिभिटिजहरू जुनले डाइरेक्टली रिलेटेड नभए पनि इन्डाइरेक्टली यस्ता किसिमका क्राइसिसहरूमा हेल्प गर्न सक्छन् ती हुन् we have been providing feedback to Nepalese government of Nepal to plans and documents, especially policy feedback. And we have been working with universities in Nepal to develop curriculum, especially postgraduate curriculum we contributed to. And also we have started working with universities in Nepal, especially about distance teaching and providing advisory services. And we have a committee called Women in Agriculture and Allied Professions. र हाम्रो विशेष त महिलाहरूलाई सशक्तिकरण गर्ने हिसाबले चाहिँ एक हामीले एग्रिकल्चर प्रोफेसनल्सहरू नेपालको, युएसको र अरू हाम्रो मेम्बरहरूलाई र बियुएन उहाँहरूलाई चाहिँ इन्भल्भ गराएर ब्रेन स्टर्मिङ गर्ने, निड एसेसमेन्ट गर्ने र हाम्रो महिलाहरूलाई इम्पावर गर्ने, महिलाहरूको इस्युजहरूलाई एड्रेस गर्ने उसमा पनि हामीले काम गरिरहेछौँ र यसको लागि चाहिँ हामीले डेटाबेस तयार गर्ने काम सुरु गरेका छौँ। On top of that, we have a strong student coordination committee, and that committee is working to provide professional guidance to students both in US, Nepal, and elsewhere. For example, in career preparation, grant writing, and providing advisory services in legal matters and other emerging issues that students are facing. हाम्रो एउटा स्ट्रङ अघि नै मैले भने हाम्रो चाहिँ रिसर्च कोलाबोरेसन एउटा स्ट्रङ कम्पोनेन्ट हो र स्कलरसिप अवार्ड पनि वी हेभ बिन वर्किङ कन्ट्रिब्युटिङ टु र रिसर्च कोलाबोरेसनमा लास्ट इयर मात्रै वी अफोर्ड 15 रिसर्च मिनी ग्रान्ट्स त्यसको लागि चाहिँ कृषि वन विश्वविद्यालयका टियु 8 जना टियुको 3 जना काठमाडौँ युनिभर्सिटीको 1 जना कलेज अफ लाइफ साइन्सेस दाङको 3 जना रिसर्चरहरूलाई हामीले सपोर्ट गरेका थियौँ रिसर्च मिनी ग्रान्टको लागि एन्ड वी रिसेन्टली कन्क्लुड द फाइनल रिभ्यू मिटिङ एन्ड दे डिड वन्डरफुल जब एन्ड दिज आर अल रिलेटेड टु फुड सेक्युरिटी एन्ड इन्क्रिजिङ फुड प्रोडक्सन एन्ड प्रोडक्टिभिटी इन नेपाल र हामीले एकाडेमिक इन्ट्रोगेटिभ एन्ड अदर अवार्डहरू पनि स्टुडेन्ट्स फोकस गरेर र केही फार्मर्स फोकस गरेर दिने गरेका छौँ विशेष त नेपालका स्टेक होल्डरलाई र त्यसको साथै हाम्रो पब्लिकेसन एउटा अर्को स्ट्रङ कम्पोनेन्ट हो वी हेभ आवर ओन जर्नल द्याट्स कल्ड ग्लोबल जर्नल अफ एग्रिकल्चर एन्ड अलाइड साइन्सेस हामीले 2टा इस्युज निकाल्यौँ यो चाहिँ पीड रिभ्युड जर्नल हो र यसमा यदि अहिले कोही यो सुनिरहनु भएको छ भने यहाँहरूले हाम्रो जर्नलको स्कोपभित्र र यदि यहाँको पब्लिकेसनहरू रिसर्चहरू छ भने यसको लागि पब्लिकेसन सबमिट गर्न सक्नुहुन्छ वी रिसेन्टली पब्लिस्ड वन बुक कल्ड Untitled Principles and Practices of Food Security भन्ने it is over 400 pages compendium of and it is going to be a good resource material for especially for the folks in Nepal. र हामीले त्यस्तै रिसर्च एन्ड पोलिसी ब्रिफ पब्लिकेसन गर्ने गरेका छौँ 6 इस्यु हामीले पब्लिस गरिसक्यौँ अनदर स्ट्रङ पब्लिकेसन वी हेभ इज एग्री कनेक्सन विच इज अ क्वार्टरली न्युज लेटर एन्ड गएको इस्युमा मात्रै हामीले कोभिड बारेमा हाम्रा रिडरहरूलाई इन्फर्मेसन दिनको लागि जुन मिसइन्फर्मेसन आइरहेको थियो त्यसलाई एड्रेस गर्नलाई आवर मेम्बर्स रोट एन आर्टिकल क्लेरिफाइङ that misinformation. र त्यस्तै we have been organizing webinar. We so far conducted 23 webinars and 19 of them are by the professionals experts and 4 were by students committee. And one of the webinars was by Dr. Sanjeev Sapkota, you all know, and it was about COVID pandemic. And this COVID webinar was very helpful to inform our members and beyond. And we also conducted, we invited Secretary of Ministry of Agriculture for one of the webinar we recently conducted, and another webinar we conducted in recent past was about post-harvest management, and these are all contributing to food security, we hope. त्यस्तै हामीलाई वर्कसप सिम्पोजिया पनि हामीले अर्गनाइज गर्ने गरेका छौँ one of the symposia that our president coordinated was organized by NRNA and it was about agriculture transformation, food security, where our members were the panelists and president was the coordinator. And we have been organizing several other webinars. Applied bioinformatics, where over 400 participants participated from across the world. So it was very popular, and we are going to offer these kind of webinars or this kind of workshop and symposia in the future. Right, yeah, I mean, there are a lot of opportunity that we can work with, we can explore. हामीले के अझै गर्न बाँकी छ हामीले प्रोभिन्सियल गभर्नमेन्ट नेपालको विशेष त उहाँहरूसँग टाइअप गरेर नेटवर्क गरेर काम गर्न बाँकी छ प्रोभिन्सियल गभर्नमेन्टहरूको निड्सहरू वी अन्डरस्ट्यान्ड द्याट द प्रोभिन्सियल गभर्नमेन्ट इन द इस्ट अर विराटनगर एरिया प्रोभिन्सियल वान आई मिन प्रोभिन्स doesn't have the same issues or problem that province number 7 has. सो त्यस्ता कुराहरूलाई एक्सप्लोर गर्दै हामीले के कसरी कोअर्डिनेसन कोलाबोरेसन गर्न सक्छौँ भन्ने कुरामा हाम्रो फोकस रहनेछ त्यस्तै अरू एग्रिकल्चर र अलाइड इन्स्टिट्युसनसँग कोलाबोरेसन कोअर्डिनेसन गर्ने हाम्रो सोच छ त्यस्तै यसलाई बढाउँदै लग्ने सोच छ अर्को नेसनल इन्टरनेसनल पार्टनरहरूसँग पनि हामीले पार्टनरसिप गर्दै जाने सोच छ भने अरू स्टेक होल्डर्सहरू वी आर स्टिल एक्सप्लोरिङ आवर इज This NAPA was established in 2016. It is only 4 years now, so we have been growing very fast. र यी सबैको हाम्रो एम भनेको चाहिँ एग्रिकल्चर प्रोडक्सन प्रोडक्टिभिटीलाई इन्हान्स गर्ने हो स्पेसली नेपाल फोकस र But these are a couple of the pictures that our students, our researchers, other faculty that were conducting the research. Yeah. And finally, way forward, most of the program that we have been conducting, we would like to continue those programs. And on top of that, what is in our mind is to conduct research on effect of pandemic on agriculture sector. There has been a lot of research, but I mean, wherever there is gap, you know, so that area will like to hit at. And also quality र frequency हाम्रो publications को बढाउँदै जाने र यसको चाहिँ युजरहरू एन्ड युजरहरूलाई चाहिँ क्वालिटी मेटेरियल दिने र हाम्रो रिच पनि एक्सपान्ड गर्ने अर्को प्रोग्राम छ हाम्रो रिसर्च मिनी ग्रान्टलाई अझ स्केल अप गर्ने प्रोग्राम छ नापाको त्यस्तै हाम्रो डेटाबेसहरू विशेष एग्रिकल्चर एक्सपर्ट्सहरूको डेटाबेस अपडेट गर्दै गएर नापालाई चाहिँ एग्रिकल्चर एक्सपोर्टको हब बनाउने र एक्सपर्ट सर्भिसेस दिने हाम्रो सोच छ त्यस्तै पब्लिक प्राइभेट नन प्रफिट सेक्टर्स नेपाल युएस र बियोन्ड सबैसँग नेटवर्किङ गर्दै जाने हाम्रो सोच छ डिस्टेन्स टिचिङ अहिलेको यो कोभिडले पनि हामीलाई एउटा लेसन्स के दिएको छ भने डिस्टेन्स टिचिङ चाहिँ यो चाहिँ फ्युचर हो यसले काम गर्छ इफेक्टिभ हुन्छ भन्ने अरू अब इन पर्सन सम्भव छैन भने त्यो हामीलाई सिकाएको छ त्यसकारण नेपालको युनिभर्सिटीहरूले नेपालको पार्टनरहरूले यसमा इन्ट्रेस्ट पनि देखाउनु भएको छ डिमान्ड पनि आएको छ त्यसकारण वी लाइक टु प्रमोट डिस्टेन्स टिचिङ प्रोग्राम एन्ड अल्सो इन्भल्भ हामीले चाहिँ विशेष त हाम्रो एन्ड युजर हाम्रो स्टेक होल्डर्सको डिमान्ड के हो त्यो एक्सप्लोर गरेर त्यो उहाँहरूको डिमान्डलाई एड्रेस गर्दै जाने र अल्टिमेटली यो सबै कुरालाई चाहिँ रिसोर्सले गाइड गर्छ र यसलाई सस्टेन गर्ने हाम्रो इज अ बिग च्यालेन्ज र यसको लागि चाहिँ हामीले अहिले ग्रान्टहरू एप्लाई गर्ने गरिरहेछौँ त्यस्तै जर्नल सब्सक्रिप्सनहरू सुरु गर्ने र मेम्बर्स कन्ट्रिब्युसन र बुक सेलहरू यो बढाउँदै गएर हाम्रो प्रोग्रामहरूलाई सस्टेन गर्दै जाने सोच छ यति भन्दै यहाँ अहिले सुनिरहेका श्रोताहरू इफ एनी वान इज फ्रम एग्रिकल्चर or allied field and you may want to consider joining NAPA र अरू केही क्वेसन भएदेखि म आन्सर दिन रेडी छु थ्याङ्क यू सो मच फर योर एन्सर
Thank you, Dr. Gimeri, for such an excellent presentation and enlightening us on great things you're doing in agricultural sector, which is not my sector, but it was, as I said, very, very enlightening to listen to that. I don't know if we have any questions in the question answer room. We don't. Maybe Pratik Chetterjee, do you want to take on from here?
Yeah. Thank you. Are we over time, on time? What's the status?
I think we're just a little bit over time, 6 minutes over time. So.
Awesome. Thank you all three presenters so far, and so for the next three presentations I'll be moderating, and we have Dr. both Acharya, we have Subratji and Smriti Vistaji. So next we have Dr. both Acharya. Let me quickly give his introduction before we move on to his presentation. So he is a medical laboratory specialist working in central New York in a reference laboratory, and he's had clinical laboratory experience for over 15 years, and he is also a fellow of American Association of Clinical Chemistry and Academy member of ISTH, and he also has clinical leadership role in both in the United States and Nepal. Without further ado, if Dr. Acharya is ready, let's move ahead with the presentation.
Thank you, Pratik. Thank you so much for the wonderful intro. My video is not working, so I have to go with the audio here. I wonder if you guys can see my slide.
Yes.
Thank you, sir. My presentation is really technical. I'm going to talk about clinical laboratory quality check, how that's going to impact us. And having worked in Nepal and US and other part of the world, I realized that there are some components that in Nepal we're lacking. And I have been advocating this when I was in Nepal. I had a lot of presentation there in PHL. I went to a Central Hospital there and in Chittagong, which is my hometown. So I just want, my presentation is very technical. I'm sorry about that. And my audio and videos are not working so well. If that is troubling to you, I'm sorry in advance. So let's move on. And interesting picture. In 1934, the testing for urine pregnancy, which now you get in 5 minutes, was done by injecting the urine of suspected females in a rabbit, and it takes about 2 weeks to get the result. So what they basically do is they inject the urine to the rabbit, and if the young female rabbit develop fevers and those kind of symptoms, that will suggest that the lady who they tested is positive. The rabbit does not develop fever, then the lady who tested is urine pregnancy negative. I kind of stipulated the cost, how much it would be in the current day cost. It will be about $5,000 to $2,000 to $5,000 if you put give and take. Today, if you spend $100, you can get your genetic map up. Mr. Prakash Paudel here is arbitrary name. This, I'm not advocating or not anything, but if you spend about $100, go to Amazon and you can just order a genetic makeup test, and you can find out how much genetic makeup you have from South Asia, Europe, or America. So we moved from that to this, and this test is fairly standard. But when we talk about the quality in Nepal, still we have a lot of gaps, and that is, if my presentation try to help fill some of those gaps, that would be my goal. If you look at the laboratory data, about 70% of electronic medical record are from the lab data. When we talk about lab testing, there are 3 phases of lab testing. The pre-analytical phase, where a doctor should order a right test, and the lab should collect right sample, and then analytical phase, where the testing should be done correctly, and the post-analytical phase, that data should be interpreted correctly. So these are the 3 basic phases. And when we are talking about quality, we are actually moving towards the 6 Sigma standard here. I'm being myself a Sigma metric quality manager. I want to go a little bit in more detail and where we are in Nepal. So these are the layers of quality. You do a daily quality control in the lab. That is the first layer. And then you also send the data for evaluation every month and get how many peers are close towards you, and you evaluate something called a standard deviation index, SDI, or CV ratio, those kind of thing. And what it basically does is you send your data and you compare with everybody in the world, having same instrument, same method, and say where you are, so that you can essentially give good result to your patient. And then there would be challenges sent by state or agencies that you should participate and should produce the data on a blinded sample. And there is annual internal audit that will help to make your data more reliable, sort of quality check. And there would be a survey that a state or Joint Commission or CMS will do, and then make sure that you are doing things in a manner that is required. So all this, what is all this quality checks means? That they mean that then you produce a correct patient result. So if you look at Nepal, all of these components are missing, and we only have, most of the lab do have daily quality control, and there is some sort of survey. So all these other layers are missing. That's why sometimes you cannot rely on some of this data. What are the layers of safety? So somebody jumps in the lab. First of all, they need to have a certification to work in the lab. Then they go through training. Then we do a competency assessment, which is whether you can really run that test or not and produce a reliable result. And then if you do not, then you have to go through this compliance testing, or if you make some mistake, then the NCE comes into play. And if you fail your blind sample short of proficiency challenge, then you have to go through our consequences, and then that leads to a citation, and then you have to do a root cause analysis to make sure that you are producing a reliable data. So that's all the component of safety, so that the patient results or data are reliable. But if you look at Nepal, all of these components are missing, and we only have these 3 components. So that's the majority of the components of safeties are missing. And it's high time, and I've been advocating this since a long time, that we should move towards a proficiency challenge or a survey kind of thing, so that we can produce a quality result. Quality result does not just come because of the big good instrument or person. There should be a multi-layer quality check that can help to produce a quality result. I'm going to go over the next few slides pretty quickly for the sake of time, and I hope to save some time too. This is a typical sigma metric for a hemoglobin A1C of the test for diabetes. You see that this lab every month can monitor where their quality level is. This blue dot shows that the imprecision is very low, accuracy is very high, and you are at the sigma level of around 5 to 6. So you're running pretty well. If you get a result in that lab, you can say with a very high degree of confidence that you are getting a good quality result. Essentially, clinical laboratories in US are moving towards a sigma metric quality system. I'm not going to go into the detail of the quality metric system. This is a typical lab which is running with a very high quality, about more than 5 sigma. They can just rely in one Westcard rule and still can produce a very high quality result. But if you're running very low quality sigma metric, then you may have to take action when you have to build multiple rules or multiple quality control materials to get a reliable result. And if you run into a problem, so for example, you did not pass a proficiency testing or quality testing, then you define the problem, you map all the current process, why the problems happen, you find the root cause, you develop a solution, and implement that solution, and then also check if your implementation worked well or not. So all kind of Six Sigma, the College of American Pathologists is one of the main organizations that handles all of this matter. This is not the only one, but this is one which take care of a lot of quality issues in United States. Like similarly, we do, the NPHL has some role, but doesn't have a lot of role. So having said that, I have focused on Nepal, working on the quality projects in the past, and presented a big part of this slide before. I would like to, if somebody is interested, I'm ready to help, and I had been working with Dr. Bhagwan at one point. So I would like to help if anybody need help, and collaborate or help them to gain quality if they are interested from the individual level and from the level of organization. We have here multiple layers of organization. We work here in the United States. Having said that, I would like to give you some of the wills. Please don't say thank you. Please don't say no thanks. I mean, and having said that, I saved a lot of time, and thank you so much. And if you have any question, please email me.
Hi, thank you, Dr. Acharya, for the presentation. I was wondering if you've had any contact or communication with the National Public Health Lab in Nepal on these series of standards, and if you're aware of any of the labs, including at some of the private hospitals, if on their standards where they fall in terms of 4 Sigma to 6 Sigma. etc.?
That's a very nice question. Thank you, Pratik. I had given presentation to TU Teaching Hospital, NPHL, and Chittagong Medical College when I was there last time, and I know everybody there. I'm from the field, and I know everybody there. I have been talking to them. We were trying to do this implementation in a private hospital in Nepal because the government hospital did not took the initiative to do that. Which was not successful. There is no lab in Nepal that are doing a proficiency challenge. Some of them do have ISO standard now, but I was trying to bring some of the quality metrics that the US or Europe or Australia or New Zealand are doing, because most of their focus is buying new instrument and dumping off the old instrument. I really wanted them to tell the message that instrument is not only the quality measure. You have to do a lot of things, and one of the free thing that they can really do is submission of their quality data every month. It's almost free evaluation. It's not 100% free, but I devised a way that if they are interested, I was happy to help them submit those data for free and get an evaluation every month and compare the data with the world, not only with their lab, but with the world. With, for example, you are running a dimension analyzer and you want to compare your quality data with the world running the same analyzer and make sure that your data falls in the group with the peer, and you do an early intervention if there is a problem. Let's say you reported a cholesterol of 140 for a quality control data, but most of the labs are reporting 160. So what that means is all your patients are also, you are reporting high because you're reporting the control high. That means all your patients also gone high. So you have to take action before it goes to a level which is not acceptable. So I have been trying and I am happy to help them, but and then some of these products are free, as I said, and I would be more than happy to help if they have question or need help.
Yeah, thank you again. I actually will be reaching out to you, and we'll try to connect with some of the people working in this field. But thank you so much for your presentation. Next, we will move on to our next presentation for today. So we have our presenter as Subrat Sitaula, who is a Master in Biotechnology graduate student with a specialization in regenerative medicine at Monash University in Australia. And currently he is associated with the renal trials team, Western Health Hospital, and he also has a passion and social need for medical research, and which led him to found a not-for-profit organization called Disaster Health Awareness and Medical Initiative after the 2015 earthquake in Nepal, which he manages with his team, even being outside of Nepal. So without further ado, if you're ready, Subrat, go ahead, get started.
Yeah, sure. I just want to confirm if you guys can hear me.
Yeah.
Thank you. I just want to move ahead with the presentation right away. Okay, good day, everyone. Good morning from Melbourne. I'm Subrat Sitaula, and today I'm presenting on the topic, the use of target-specific bacteriophages for the bioremediation of water bodies contaminated by multi-drug resistant pathogenetic bacteria. So at first, let's have a look at my table of contents. Moving on to the slides, I'm going to start with the overview of multi-drug resistance. In a classical situation of microbial infection, a general practitioner or a doctor would prescribe antibiotics to help the patient recover. But nowadays, in an evidence of a lot of medical practitioners, the patient would not be responding quite well to the antibiotics. Then the doctor either goes for a prescription of another group of antibiotics, or maybe he could go for an antibiotic susceptibility test, AST. And in case the microbial agent is resistant to the group of antibiotic planned to administer, then this situation is called as a antibiotic resistance. So there is an average of 2 million drug resistant scenarios in the United States alone in a year, and 23,000 deaths attributed to MDR pathogens. Moving on to the next slide, bacteriophages are the viruses that can infect and replicate within the bacteria and archaea. First discovered in 1917 by Felix D. Harrell, phages were utilized for the treatment of infections in between 1920 and 1930s. Later, after the discovery of antibiotics in 1928 by Alexander Fleming, it was overshadowed due to the multiple benefits and fast-acting potential of antibiotics. If we are not already aware about the concept of holy water Gangazal, it was the presence of bacteriophages which backed up the science behind the immense mythical significance of Gangazal in Hinduism. The animation below shows the life cycle of bacteriophages and how it absorbs to the surface, how it injects its genetic material into bacterial cell. The bacteriophage exploits the host genome to lyse the cell, and at the end, it releases its new progeny to the surroundings. Heading to the next slide, let's talk about the current implication of bacteriophages. Bacteriophages are used widely in genetic engineering as vectors for gene transfer. Bacteriophages are used in fast therapy for bacteria-specific infections and fast treatment in livestock, plants, poultry, and fish. United States Department of Agriculture has approved bacteriophages to treat cattle and poultry prior to slaughtering so that the Salmonella and Escherichia coli contaminations of the meat could be avoided. And fast typing is one of the measures to utilize bacteriophages for the detection of the susceptible bacterial species. And in the end, I'll talk about fast-based water treatment. Bacteriophages are biological systems which are as quick as less than half an hour to complete a replication cycle. They are adaptive to the host evolution, unlike antibiotics, and only small titer can effectively reduce bacterial load in a solution, and they're very specific to the subspecies and strain levels of the bacteria. So in the next slide, I'll talk about the research hypothesis I had in my research. Multi-drug resistant can be detected in wastewater pathogens. Second is bacteriophages can be found in the same source where you find the bacteria, and this process can be retrieved and replicated in the laboratory itself. And the third one is specific bacterial species can be targeted with a diverse population utilizing a narrow spectrum of bacteriophages. Next slide is about the aims of my research. My research was aimed to isolate the MDR, multi-drug resistant bacteria, and respective phages so that it could inhibit their growth and at the end of the day, not affect the ecologically significant non-pathogenic species in the surroundings. And the significance of my research. As mentioned in my previous slides, it is an effective treatment for the multi-drug resistant species of bacteria. Next, they abundantly administered antibiotics, which are being very less effective every single day, and the pathogens are growing stronger. Further, completely a new genre of antibiotics cannot be, is not able to currently address the issue of resistance, and it has not yet been approved. And at last, no matter how strong antibiotics we discover, bacteria will continue to evolve and develop resistance because they are one of the earliest inhabitants of this planet. Let me tell you about the research design and protocol in a brief. First, isolation of bacteria, and then I moved on with the multi-drug resistant conformations. Later, I went for isolation of bacteriophages from the same water I retrieved, and the isolation of the planting of bacteriophages in artificial in vitro media. And later, I went for the host strain spectrum analysis of the bacteria. So these are the observations I retrieved while I worked in the laboratory of Kathmandu University and Monash University. So basically, I used the wastewater from Bagmati River, which is one of the famous and even it covers a huge area around the valley. So a range of selective agar and biochemical tests were utilized, and I selected 5 pathogens, namely E. coli, Bacillus, Klebsiella pneumoniae, Enterobacter species, and Acinetobacter baumannii. Later, I selected Acinetobacter baumannii because it had a lot of MDR, MPR resistance positive tests, and I isolated it from the river itself, and it had it has very significant relation with the hospital-associated infections. And then the clear zones seen on the left corner, it's called the plaques which were observed in the long cultures of bacterium, which confirm the selective lysis of the bacteria. So the other bacteria, except for the one I targeted, were still alive in the same plate, and I could selectively lyse the bacteria I wanted to. So in the next slide, I'll talk about the potential risks and the factors that I would utilize to reduce the risks. So first of all, bacteria can evolve to be resistant to the phages too. But like bacteriophages also evolve very rapidly, and the host evolution, sorry about the video. Okay, bacteria can evolve to be resistant to the phages too. And bacteriophages can also evolve very rapidly and continuously parallel to the host evolution. And some bacteriophages might pose a serious threat to the indigenous microflora in the ecosystem, which too can be controlled by silencing some genes of replication in the bacteriophage itself. And the third one is the administration of phages to eliminate MDR bacteria can also eliminate the closely related microbes in the water system as well. But this can be this threat can be reduced by the effect of by utilizing the effect spectrum of the bacteriophages, which can be regularly monitored, and we can avoid the elimination of the desired species, which we still want them to survive in the ecosystem. And this slide has a few new researches and studies which question the ability of bacteriophages to invade human cells as well, including the cells of the central nervous system. But this has been quite nicely addressing some researches. So these genes can be silenced before we actually use bacteriophages for bioremediation. So let's move on to the upscaling plants and the plants outside the laboratory. So Bagmati has been contaminated for quite some time, and we also have been hearing about Bagmati Sarsafai Abhiyan for quite some long time now. So it's worth a great appreciation that the physical cleaning have been performed, but the physical treatment of the contaminated water is not sufficient to reduce the bacterial load and the associated infections in the river water itself. The direct disposal of household waste, industrial sewage, and medical waste are some of the notable causes to it. And at the end of the day, a biological method of treatment would be one of the most safest and most reliable forms because it can be sustainable, and it also can be utilized to bring back the water to its naturally abundant form. I think this is the end of my slides. These are my references. And yeah, I'll be welcoming any questions if you have related to my work. Thank you.
Thank you. Thank you so much, Subratji. I just have one quick question. Are you aware of any research on bacteriophage relating to COVID-19?
No. I might not be reaching out that well about the bacteriophages related to COVID-19 because bacteriophages are very specific to bacteria, so they might not be good system to study for our virus itself.
Okay. Thank you for that clarification, and thank you for your presentation. So because of time, we are going to move ahead to our next presentation.
Sure, thank you.
And thank you, Subrat. and it's from Smriti Vista. And Smriti she's ready, and she's a General Secretary of Disaster Health Awareness and Medical Initiative, and she's currently also in Australia as a student. And without further ado, if you're ready, Smriti, let's move ahead. Thank you.
Thank you so much for the introduction. So I want to share my screen. Sorry, good. Sorry, I'm not able to share my screen.
Do you need help? Like, there's a share screen button down there in green.
Yeah, I did it, but then I don't know why it's not.
So I have your presentation open, so I can go ahead and share my screen and
yeah, and then I made some changes in it.
Yeah. Here we go. Are you all able to see it?
Yeah.
Yeah.
Okay.
Can you put it on full screen? It's.
Can you put it on presenter view, please?
So.
Thank you.
Okay, thank you so much. So, shall I start?
Yeah, go ahead, please.
Okay, hello everyone. I'm just going to present our work. So basically it's mine and Subrat's work together. Subrat, who just gave his presentation before me. And then it's about our work during the time of earthquake, which all know it occurred on 25th of April, 2015. So moving on to next slide, please. Thank you. So these are contents. Then, sorry, next please. I have to tell this again, sorry. So yeah, so as we all know that earthquake hit Nepal with magnitude of 7.8, and then so the devastating earthquake killed nearly about 9,000 people, and 22,000 people were injured. So yeah, we just lost almost 10 billions of our nation's property and everything. And after after earthquake, we just decided to help people out there. And then moving on to next slide, please. So yes, we just went out, and then we went for observations around, like we could see all the centuries old buildings were destroyed. We just observed situations around, and then witnessed the people. They were helpless and helpless and also homeless, and they required health facilities, and then they were not getting the facilities in time. And also the aftershocks were just affecting people's life. So yeah, and then we just planned. So yes, me and Subrat, we just planned to help people through the situations. And then let's go to the next slide, please. And yeah, we just help. We just help by our own, like with help of my family and friends. To try to distribute the medical supplies to needy people, and then we try to bought some stuff at our own, like Pius water purifier, which was very important at that time, and then the betadine, cotton, bandages, mask to local people like around the neighborhood. And then yeah, of course it was not enough for us. There were a lot more people suffering out there. So at first we just distribute locally around our house. We went to the dislocated people in the high ground in Chavel, and then we just aware them about the water purifications. We distributed PPUs there, and then later on we started collecting medical supplies from different organizations. And then we just made a homemade pouch out of newspaper, and then we just it included the newspaper packets included all the necessary first aid equipments, like a mask, cotton bandages, povidone-iodine, and then Dettol soap. And then we also made at that time it was there was short of face masks, which we just made it at home. We bought the supplies and then made it at home, and then we prepared it and we just sent it together with other first aid kits. Next slide, please. I just explained this one, sorry. Next, please. These are the details that we prepared. So basic first aid kits, and also the hygiene kits and water purifier, everything. And then moving up to next slide, please. And then we started to, at first we just distributed it to the local people, and then later on we supplied 9 boxes of first aid kits. So each package of 150 to 200 packets were there in each box, so 9 boxes. We just send it to Bhattara, Ramechhap, Kabrepalanchok, and Rashua with the help of Nepal Army Rescue Chopper. So we were the first people to send first aid kits to Rashua, basically. And then, of course, the homemade solutions that we made, and then masks, everything, we just tried to make them reach. And then later on, in the next slide, we started collaboration with the different organizations to work more. We just wanted to work more at the time. And then, we went to the organizations like Lead International, Samriti Foundations, Navajagaruk Yuva Club, to distribute medical kits. So simply we took from them, we repacked it, and then we just sent to different places. And then of course, from Dr. Sanjeev Sapkota helped us a lot during that time. So we got medical supplies, like a lot of medical supplies from NRN office. And then, moving on to next slide. So yes, after all of the work we did for many months, and then we just decided to work for this, so that we just registered an organization's name under Disaster Health Organization and Medical Initiative. So we had a team of doctor, engineer, architect, biotechnologist, and then we registered it, and then under this banner we started giving presentations to different school colleges about the earthquake evacuation plan, continental drifting, safety tips for earthquake. And then we educated through presentation slides, and almost 2,500 students and teaching staffs were educated. Also, we gave informations to primary schools with their parents together. So we did this almost for 1 year. We were just working on it, and then that's all it's about. So yeah, after that we just came to Australia for further studies and we couldn't continue it. But then of course later on we might go to Nepal and do it again. Even right now we want to, but we can't. Staying far from Nepal, yeah. Thank you so much.
Great, excellent. Thank you, Smriti-ji. It was great presentation from yourself as well as from everybody. I don't know if Pratik-ji has anything else to add or any questions. I don't see any questions in the chat box here. But thanks for sharing your experience. That was great.
Thank you so much.
Pratik-ji, do you have anything else to add before we wrap up?
No, but except to thank all of you, all the 6 wonderful presentations. And, you know, some of you are deep into leading into midnight and some of you are in daylight. So yeah, thank you for making this virtual session possible, even during these hard times. Thank you all of you for your
Thanks.
and
I totally echo Pratik-ji. Thank you for, you're in different time zones, and thanks for being here. Thanks for making it a success. We had a lot to learn from each one of you, and we covered a lot of grounds, different topics, from medicine to agriculture to earthquake relief to everything. And I could also see some potential collaborations developing in the chat section. So that's really a marker of success of such a forum. So thank you, everybody. It was a pleasure having you all. I hope we'll cross paths in real life. Good night, good morning, wherever you are. Bye.
Thank you so much. Bye-bye.
Thank you so much. Bye-bye.